So, good evening, everybody. Like day 1 and 2, the day 3 also is decorated with highly informative sessions and great eminent speakers. So, starting with session 1, which will be chaired by Dr. Haresh Doshi sir and Dr. Jignesh Shah sir, and the sessions will include oral MST by Dr. Sudha Sharma, non-hormonal medication for menopause by Dr. Jyoti Jaswal, and Tibolone by Dr. Shobana Mohandas. So Dr. Haresh Doshi sir, he is a professor and HOD of Obs and Gynae, GCS Medical College, Ahmedabad. He has multiple books and chapters to his credits and has been faculty for more than 250 times. Dr. Jignesh sir, hello. Am I audible?
Yes, ma'am.
Dr. Jignesha CV is not being displayed. So I request my chairpersons to
Hello, ma'am.
please.
Sir, CV yet to receive. You just go ahead now.
I request my chairpersons to please introduce the speaker of the first speaker of the first session, Dr. Sudha Sharma.
See, Dr. Jignesh Shah was the president of IMS, no?
Yes, yes, ma'am.
2000 pandemic time. I think 2019, 2020 like that.
So I would request Dr. Haresh sir to please introduce our first speaker of the session, Dr. Sudha Sharma. Jignesh sir. Dr. Ashna, will you like to introduce?
Madam Haresh sir is joining, but you. Sudha Sharma ma'am also not joined, madam. Let me try.
In that case, can we go ahead with Dr. Jyoti Jaiswal?
Yes, yes, ma'am.
Can
Okay,
somebody
ma'am.
call Dr. Sudha Sharma and alert her?
Yeah. And Haresh Doshi also joining. I just called him.
Please start with Dr. Jyoti Jaiswal's talk.
Hello. Hello.
Yeah, hello.
Archana, am I audible to you?
Yes, yes.
So should I? Hi, Archana.
Jyoti ma'am, please share.
I'm
Archana,
here. Let me share my screen.
Yeah. Sorry to interrupt, Jyoti. Just one information. Dr. Sudha has some emergency, so as she's free, she'll join. So we'll take up the next speaker, Archana, for your information. Yeah.
Okay. I need to wait now, na?
You can start because if she's not there, please start. And because madam is into some emergency.
Should I try to share screen?
Yes, you
Yeah,
do that.
Jyoti. Yes, Jyoti. Go ahead, present.
Is my screen visible, madam?
Yeah, it is. Make it slideshow. Make it slideshow.
Let me go to the first slide. Is it okay now?
Yeah.
Right at the first slide I am. At the heading slide I am here, the non-hormonal medication for menopause.
Yes, ma'am.
Yeah,
yes.
correct. Go ahead.
So thank you very much, Shobha madam, Dr. Archana and whole ICOG Foxy team to give me this opportunity. And I am here to talk about the very specific part, non-hormonal medication for menopause. So why non-hormonal treatment is required? Why we need to, because there is a problem with the hormonal decline. So why there is non-hormonal treatment which can help us? Because there are many situations where the MST is not, either it is not feasible or it is not acceptable, And then sometimes the non-hormonal medication had better effect for a particular issue. So where we cannot give MHT, like in contraindications to MHT, fear of long-term use of MHT, fear of adverse effects of MHT, and lack of information about MHT, which is still in the few at the few areas of the country. So, and the another thing is non-hormonal medications have an extra edge for menopausal symptoms management at many conditions, like in cases of, you can understand, like in cases of depression with the menopausal symptom. So, contraindications for HRT we'll keep aside, and in those cases, we'll not allow HRT. So, we'll do what? We'll go for the other treatment options, and those treatment options include lifestyle modification, alternative therapies, non-hormonal medications, vaginal treatment, mind-body therapy, etc. And out of all these, lifestyle modification and alternative therapy is already being covered, and I will be specific to non-hormonal medications. So I'm skipping the lifestyle modification, which was covered yesterday: nutrition, exercise, avoiding triggers, sleep hygiene, alternative therapies, etc., and coming directly to non-hormonal medications. Now there are few areas with the different kind of medications, like for the short-term problems related to the menopausal symptoms, or medium term, like the vasomotor symptoms, and the long term implications like the bone health is there. So, non hormonal medications for bone health, that is bisphosphonates, raloxifene, calcitonin, parathyroid, all those already covered. Similarly, the non hormonal medication for genitourinary syndrome of menopause includes oxybutynin. We'll focus more about the non-hormonal medication for VMS, which includes SSRIs, SNRIs, gabapentin, neurokinin 3 receptor antagonist, and nowadays a new entity, stellate ganglion block. So coming to the more common and very effective group for the treatment of vasomotor symptom, that is SSRIs and SNRIs. These are the most commonly used in clinical practice for the alleviation of menopausal symptoms as an alternative to MHT. Both SSRIs and SNRIs are effective at relieving vasomotor symptoms very efficiently. SSRIs including escitalopram and paroxetine. I have a personal experience that those medications are very good for elevating the symptoms, and in SNRIs, venlafaxine were shown to be the most effective. SNRIs are associated with more adverse effect, but venlafaxine is preferred in women with breast cancer because SSRIs may interfere with tamoxifen metabolism. Before prescribing them, you need to go through the proper history, and you need to know that there should not be any prior neuroleptic syndrome or serotonin syndrome or concurrent use of the MAO inhibitors, because these are the contraindications for SSRIs and SNRIs. And you need to be cautious if the patient is having uncontrolled seizures, bipolar disorders, kidney or liver insufficiency, uncontrolled hyponatremia, and poorly controlled hypertension. Along with also, you need to see that patient is not on any other SSRI or SNRI, because they can have the combined effect and the pertinent polymorphism in cytochrome P450 enzyme pathway. You need to check. So what are there are so many drugs, but the common drugs I have just mentioned here to keep the clarity: escitalopram 10 to 20 milligrams per day, paroxetine salt, which is FDA approved for the treatment of moderate to severe VMS with the improvement in sleep disruption and without weight gain and negative effect on libido. The dose is 7.5. So this is about FDA, but you can go even up to for the higher dose, that is 10 to 25 milligram per day. Citalopram also can be given in the similar dose with the escitalopram. Coming to the SNRIs, so SNRIs inhibits the reuptake of neurotransmitter serotonin and norepinephrine in presynaptic neuron association with mild to moderate improvement in vasomotor symptom, and it improves hot flashes frequency and severity. At least the numbers and the severity gets decreased. Contraindication here will be the heart disease, uncontrolled hypertension, dyselectrolemia, and it should be given with caution in cases of the liver disease. So before prescribing them, you have to go through the history and the investigation before prescribing them. The dosage is for the desvenlafaxine is 50 to 150 milligram per day. It can be given as 75 milligram per day single dose or twice. And venlafaxine, the minimum dose is 37.5 milligram, and we should always start with the minimum dose, and it can be increased up to the 75 or even up to the 150 milligram. The another option with us is gabapentinoids, and gabapentin is otherwise FDA approved as an anti-epileptic drug, but it is also can be used for the improvement in the frequency and severity of the VMS. The majority of the trials took 900 milligram dosage. Drowsiness is an adverse drug reaction with the gabapentinoids. So that adverse drug reaction can be used as a good choice during if we can take it at the bedtime. So good choice for the women with disruptive sleep from VMS. And the dose should start with the 100 to 300 milligram at night. You can add furthermore 300 milligram at night, and in the morning 300 milligram. So in that way, we can increase up to maximum 2400 milligram. 900 is a common. Clonidine. Clonidine has a mixed reaction with the literature. It is a centrally active alpha-2 adrenergic agonist, and it is more beneficial than the placebo, but less than the SSRIs, SNRIs, and gabapentin. It is not recommended by the IMS or NAMS and many societies related to menopause management, but it is licensed in UK for hot flushes. There are more effective therapies with the fewer side effects than the clonidine, so it is not a first choice kind of thing. The dose is 25 microgram twice daily for 2 weeks, increasing up to the maximum of 50 microgram 3 times a day. A new thing is coming up, that is neurokinin beta antagonist, NK3 antagonist. The neurokinin 3 receptor antagonist is new emerging treatment, and they rapidly reduce the number and the severity of the hot flashes. The drug fezolinetant, NK3 receptor antagonist, which is also coming with the name of Vioza, just because it is a new drug, so I am also telling the name. Otherwise, fezolinetant therapy is currently in the clinical development, which acts by blocking NKB signaling and decreasing the activity of KNDY neurons. It is in first-in-class neurokinin B antagonist that is FDA approved. The dose is 45 milligram per day per oral to be taken. Coming to the oxybutynin. See, oxybutynin is an antimuscarinic, anticholinergic therapy, and it is used for the treatment of overactive bladder and urinary urge incontinence, which is also common with the menopausal age group. But it also works well with the improvement of the moderate VMS. So it can be used in those cases where these problems along with VMS is there. So you need to see about the adverse events, that is the common problems with the antimuscarinic, anticholinergic, that is dry mouth and urinary difficulties. And it should not be taken for the long term because it can be associated with the cognitive decline. The dose for oxybutynin is 2.5 milligram to 5 milligram twice daily, up to maximum 15 milligram extended release daily, and it can be used for the short term period. So, coming to a dose summary of non-hormonal medication, which is very important because we all can prescribe all these drugs, but as a routine we do not prescribe, so we should have a summarized table form, and we should know that in which kind of patient which non-hormonal medication is better. So escitalopram, SSRI is escitalopram 10 to 20 milligram, paroxetine 7.5 milligram, not effective, then you can increase. SNRIs, desvenlafaxine or venlafaxine 37.5, you can increase up to 150. Gabapentin, start with the 300, go up to 900. If required, you can add more. Clonidine, not a preferred drug. Fezolinetant, 45 milligram per day, nowadays available in India. Oxybutynin, 2.5 to 5 milligram twice daily, as and when required, with the other symptoms in which the oxybutynin is more indicated. For the bone health, as I said, it is already covered, so I will not go into the detail, but sclerostin inhibitors, bisphosphonates, and calcitonin can be taken for the long-term management of the symptoms of menopause. The stellate ganglion block is a new thing, new technique, which includes local anesthetic injection into the stellate ganglion right here. And it is recently used in cases of those who are refractory to the other treatment or contraindicated to HRT, like in women with breast cancer. Vaginal treatment will be covered separately, but vaginal moisturizers, lubricants, they are very good, and the local treatment is very, very important to alleviate these symptoms, especially the gels, which are including hyaluronic acid and the glycerin contain water soluble lubricants. They are highly effective and they give a lot of relief to the patient. Nowadays the laser therapy is also adding on for the the laser therapy rejuvenates the area, local area. So frictional CO2 laser or erbium YAG laser can be used. It can restore the vaginal epithelium as in the premenopausal state, increase lactobacillus and other premenopausal flora, as well as improve the vaginal health index score and subjective symptoms of GSM. The mind body therapy includes the cognitive behavioral therapy, mindfulness based interventions, clinical hypnosis, spaced respiration, and relaxation. All, and it itself is a big topic, but it is a mandatory part. So, simultaneously, hand in hand, these type of management and the medical management should go hand in hand. So finally, coming to the recommendations, the recommended non-hormonal therapies includes SSRIs, SNRIs, gabapentin, oxybutynin, fezolinetant, cognitive-based therapy, clinical hypnosis, weight loss, stellate ganglion block. There are few other kind of medications and other kind of supplement and other therapies also there, but the sufficient evidences are not there. There is insufficient evidence. Those include supplements of herbal remedies, soy extract, yoga and exercise, cooling techniques, cannabinoids, acupuncture, and chiropractic interventions. So this was in a summarized form about the non-hormonal medications for the management of menopausal symptoms. Thank you very much.
Audio. Thank you, Madam Jyoti, for nicely covering the non-hormonal part of menopausal therapy.
Thank you, Arish sir.
Menopausal therapy. You rightly mentioned that the drugs which are more important are SSRI, SNRI, gabapentin, clonidine, okay, and the newer drug which is now approved by FDA, that is Vioza, right? Oxybutynin. Vioza is a neurokinin beta antagonist and works very well, right? Uh, these drugs have a all effect of menopausal, right? All symptoms, hot flushes, vaginal symptoms, and bone. When you speak of bone therapy, it is more on bones. When you say vaginal therapy, it is more on vagina. So I would rather prefer for my patient, if she has a more than one system symptoms, then the drugs are better than these. Of course, the hormonal therapy is the first choice, but non-hormonal, these are very important. And what I saw from your last slide, that this yoga and exercise are not a sufficient evidence. Normally, we advise this our patients. Now they are free from their social life and they can, because everywhere yoga, 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 right? And exercise also helps in weight loss, and that's how it can help in bones and other things. What is your opinion, madam?
Sir, these things are taken from the North American Menopause Society guidelines. And yes, all these things are in general very, very beneficial for the positive aspect of life, and they are definitely beneficial. But when they are compared for an effective treatment for the VMS, especially which is the more alleviating symptom of the menopausal symptom and immediate symptom, these things do not do much, but adding on them is always a benefit, never a harm.
Yes, you're right, right. So this non-hormonal therapy
Because
as
I mentioned specifically it here because many a times just doctor prescribe yoga, dhyana and this and that exercise and patient do not get the benefit of the alleviation of symptoms. She continues with the symptoms and feels that nothing is being done. So these things are not very effective. That they can be used concomitantly, but the medications, if required for a moderate or a severe kind of problems, then they should definitely should be added on. So this is my message.
good. So after in our times after WHO report, we report of hormonal side effects of hormonal therapy. This non-hormonal got a momentum, and now we have a big basket available for non-hormonal. I mean,
So we are very
oral
pro for
therapy.
the MHT, but then MHT has only few indications where it can be given.
Yes,
And there are few areas, like I said, at depression. MHT is never an indication for depression. But if the depression and
correct.
vasomotor symptoms are combined, then these SNRIs, SSRIs are very effective.
Right. Wonderful. In a short time, you have covered everything, madam. Good. Congratulations.
Thank you.
May I
Thank you.
have the next? Yes, next speaker is Dr. Yes, she was the first speaker, Dr. Shudha Sharma, madam, right? She from Jammu and Kashmir, professor and head of the department. She is my good old friend. Vice President IMS 2024-25, Secretary General IMS 21-22, Honorary Professor IMA, Managing Committee member of PCOS Society of India, Editor-in-Chief. I have contributed many chapters in that journal, madam. Member Editorial Board, Editorial General JK Science, Member National Advisory Board and Journal Committee, Chief Editor. She is more on a publishing side, wrote many papers, edited many journals, member of Editorial Board, right? Madam Sudha Sharma, please. She'll be talking on menopausal hormonal therapy, MHT, not now we don't call it HRT. Thank you, madam.
Thank you, Dr. Harish Doshi, for such kind introduction. And yes, you are very right. We have a very long association, a very good friend. Thank you, ICOG, for this invitation. Is my screen visible?
Yes, ma'am.
My topic is oral menopausal hormonal therapy. If Shakespeare had been a chemist, he would have loved estrogen, a hormone fit for comedy, tragedy, and a sonata too. That's what I feel. Estrogen can be heroic, governing human fertility, nurturing the heart, wounds, feminine curves, blood vessels, and brain, but can play Lady Macbeth with blood on her hands, as it has been implicated in many untoward side effects, but if used imprudently. So the history of how menopausal hormone therapy, or HRT, grew is very fascinating. In 1800, people suspected that something goes missing in a woman's body after menopause. So for few decades, bovine and porcine-derived ovarian tissue was being used in women with sexual dysfunction and menopausal symptoms. Then in 1900 and 1933, first bioidentical menopause hormone from pregnant women's urine was put up for sale. But since it was too expensive, it was replaced by oral Premarin in 1941, which was, given FDA approval in 1942 for hot flushes. So this, became, very common use of Premarin was there, and FDA approved Premarin in 86 for hot flushes, osteoporosis, and even for chronic diseases. So the concept was, you take Premarin, you will be feminine forever, you will be healthy forever. And it became the best-selling drug. Nearly 1/3 of all the prescriptions were given to these women well past their menopause, till the publication of WHI results in 2002, which changed the attitude of HRT dramatically. All newspapers, all magazines, they linked HRT to cancer and stroke. And millions of women in US and around the world they stopped taking hormones. This left many women suffer from adverse changes in their quality of life following cessation of HRT. But over the years, follow-up of these cases were done, and many organizations, many societies have now given the guidelines and the recommendations, and we still have many indications for menopausal hormonal therapy. All eligible women less than 60 years of age or less than 10 years postmenopausal who have vasomotor symptoms, genitourinary syndrome of menopause, POI, osteoporosis prevention, but in those who are at high risk of fractures and are ineligible for specific bone active medication, early menopause up to the natural age of menopause, and emerging data, gives the recommendations and the guidelines. Various forms of MHT are the estrogens, progestogens, combined therapies, androgens, SERMs, and tibolon. Now, 17-beta estradiol is the best one. It metabolizes to estrone, estriol, and estrone sulfate, biologically very much similar to ovarian hormones. Then we have estradiol valerate, slight modification of natural molecule. This is the esterified form, which metabolizes in the liver to 17-beta estradiol and valeric acid to estrone and then to sulfate. Then CEE, conjugated equine estrogen, has been the most frequently used estrogen up till now. It's a mixture of estrogen, which is derived from urine of pregnant mare. Hepatic potency is 2 to 3 times higher than that of estradiol. It's a variable mixture that also contains up to 200 other steroidal substances and has less than 5% estradiol. So from scientific and pharmacological point of view, this mixture should no longer be used since oral and transdermal estradiol is very much available. Then we have estriol, mostly used in vaginal preparations. Estradiol is under investigations and very upcoming salt to be used in menopausal hormonal therapy. Ethinyl estradiol, one of the most potent compound, but used in OC pills. Now, we all know that estrogen receptors are present from tip to toe, and they have so many, effects in a female body. They protect the bone by inactivating osteoclast. And the meta-analysis have suggested that, they decrease the level of triglyceride, LDL, and they increase HDL. And some studies show that oral preparation, they increase HDL-C, SHBG, and also increase in triglycerides. Now, so these are the dosages. Conjugated equine estrogen, CEE, we know ultra dose, low dose, standard dose, and high dose. 0.15, 0.3, 0.6, 1.25. Similarly, 17-beta estradiol, 1 is the low, standard is 2, and estradiol valerate is low dose 1, standard 2, and high is 4. Progestogens. Micronized progestogen. Several recent observational studies now support the use of natural progestogens in hormonal therapy. Since it has fewer side effects than synthetic, not androgenic, so no adverse effect on lipid profile. And also it does not increase the risk of breast cancer. Dydrogesterone, another salt, endometrial protection is given nearly up to 97%. And in the regimens, progesterone should be prescribed for a minimum of 12 days in a month to reduce the risk of hyperplasia or carcinoma. And during perimenopause, sequential regimen is used, which provides a regular withdrawal bleeding. In postmenopausal women, continuous combined regimen usually prescribed because that reduces the incidence of breakthrough bleeding, but should be given in a lower dose throughout the cycle. Now, these are, the dosages, micronized progesterone, oral 200, vaginal 100. And in high dosages, if estrogen is given high, then oral should be 300, vaginal 200, dydrogesterone 5 and 10, and LNGIUS 0.02. Side effects, we all know: weight gain, bloating, irregular bleeding, breast tenderness, anxiety, and sometimes even depression. Now, androgens. Current guidelines do not advise the use of androgen therapy, although transdermal testosterone is licensed for use in Europe. FDA still refuses the approval of female androgen replacement therapy. Progesterone, once daily vaginal insert, is now first FDA approved androgen, and DHEA for use in dyspareunia. SARMs. Basidoxifene is the third generation SARM with agonistic action on bone, antagonistic action on the endometrium. It prevents vertebral and non-vertebral fractures without stimulating breast and endometrium. A combination of basidoxifene 20 mg, CEE 0.45 mg is effective in treating vasomotor symptoms and bone loss. It is licensed for use in many countries, but yet not available in India. We have another SERM, osmifene, third generation SERM, which is approved for oral use for treatment in dyspareunia in the dosage of 60 mg per day. So how do we evaluate the endometrium under hormonal therapy? It's a well-known fact that unopposed exogenous estrogens increase women's risk for endometrial hyperplasia and carcinoma, and this effect is both dose and duration dependent. So women who receive sequential hormonal therapy, that means first estrogen and then progesterone, endometrial thickness is expected to vary throughout the cycle, whether the endometrium undergoes proliferative or secretory transformation because of estrogen or progesterogenic stimulation. And the examiner should have the knowledge of type of hormonal therapy and the day of menstrual cycle when he or she is doing the ultrasonography. And the best time to examine endometrial thickness should be early post-menstrual period. Now, the women who receive continuous menopausal hormone therapy, that means everyday estrogen, everyday progesterone, in them the endometrial thickness would always be same, that means thin. So the recommendations are only for women on sequential therapy. Women on continuous therapy should be regarded and followed as postmenopausal women without therapy. But endometrial thickness of all the women to be assessed before the onset of menopausal hormonal therapy. And ET up to 8 mm is regarded as normal finding. ET of 9 mm or more is suspicious, needs further evaluation. Now, this is a very recent white paper which has been issued by International Menopause Society in this month only. I think just 1 week ago, addressing the key controversies in menopausal hormone therapy. So the key point summary of the principles of prescribing menopausal hormonal therapy by International Menopause Society in this white paper says that MHT is primarily indicated for symptomatic women. It should not be regarded as an elixir of youth. MHT is not currently indicated for primary prevention of cardiovascular disease or dementia. But in those females who are having primary ovarian insufficiency or early menopause and are getting menopausal hormonal therapy because they are symptomatic, the usual, preventive benefit would be given for these cardiovascular diseases, even bone or dementia. Healthy women at usual age of menopause can have oral MHT if they prefer, if they cannot absorb or are allergic to transdermal estrogens. Body io-identical progesterone and body similar progestrogens have less adverse impact on cardiometabolic and breast risk markers than endogenous progestrogens. Prescription of MHT should be at its minimum but fully effective dose to achieve maximum benefits with minimum adverse effects. If the dose of estrogen is increased, then the dose of progesterone should also be increased to maintain the adequate endometrial protection. Other options may be off-license or available in some countries that include vaginal progesterone, intrauterine LNG, and oral tissue selective estrogen complex, that is TSEC, which is yet not available in India. The primary indication for testosterone replacement in women is hypoactive sexual desire disorder, distressing low libido. Testosterone preparations remain off license for women in most countries, requiring down titration of male preparation, such as gels, typically 1/10 of male dose. MHT is currently indicated for women in menopause and late menopause. Menopause is associated, menopause associated symptoms, they are often noticed in many premenopause and early menopause female. So MHT to them can be given off-label, but there may be higher incidence of adverse effects due to intermittent endogenous estrogen production. So we have to be cautious about this. So when should MHT be stopped? Arbitrary limit, that is 5 years, should not be placed on duration of MHT. A personalized approach should be employed. empowering women to make an evidence-based individual decision. Ongoing use of MHT rather than initiation of MHT in women more than 60 years be associated with a more favorable risk-benefit profile for cardiovascular or VTE event. So, supporting a woman in making a decision, the risk of MHT must be considered in perspective for each woman and should be balanced against the benefits. Management of menopausal symptoms should be tailored to the individual woman to effectively manage her symptoms and minimize the risk. For some, any extra risk will be unacceptable, but for others, they may feel that the benefits outweigh the risks. So it should be offered to all those who really need it, and it should not be denied for having a good quality eye. Thank you. Thank you very much.
Thank you, Madam Dr. Sudha Sharma, for nicely covering the whole topic. As my co-chairperson Jignesh is not there, he is busy with other webinar. I am commenting. Well, you clearly mentioned everything about these two molecules, mainly the right estrogen, E1, 2, 3, now E4 is coming. That how to start, when to stop, and which progesterone is better, progesterone natural or synthetic? Obviously natural, as you mentioned, is better. And the dose used to be minimum, but is it still effective, and not the side effects should not be there. You clearly mentioned testosterone is approved in Europe, but not by FDA. But in our country, people are still using it off the record. And I have seen my teacher using, right, and with good results in very, very few patients. So hormonal therapy is like, as you mentioned, should not be used like elixir of youth or young forever, only indicated for symptomatic women. And as you mentioned, I also say that we should go read that white paper, latest available now, IMS Society white paper, key points in menopausal, right, hormonal menopausal therapy. Because patients sometimes come with Googling everything, and then if you don't know, so you have to be updated with the latest things. That is very much required. Thank you, madam. Wonderful, wonderful.
Thank you. Thank you, Dr. Joshi.
Now, the last speaker of this session, Madam Dr. Shobna Mohandas, she will be speaking only one molecule, Tibolon, right? Some that is. She is consultant gynecologist and laparoscopic surgeon, Sun Medical Center, Thrissur, past president of Indian Menopause Society 22-23, past president of IMA Thrissur, past secretary general, quiz chair and website chair, IMS, founder secretary, Calicut Menopause Society 2009, organized several endoscopy workshop and CMEs, South Zone coordinator, Foxy Hysteroscopy workshop 2011, pre-paper chairperson, AISOG 2016, past active member of Foxy Endocrinology and Food and Drug Committee, invited faculty at more than 400 venues, more than 400, very important figure, nationally, authored 2 textbooks in gynecology and contributed chapters, so many textbooks, graduated and postgraduate from Grant Medical College, Mumbai, 1980 to 1986. I also passed in that year, same year, madam. Okay. Madam is going to speak about the Tibolon, again, a wonder molecule for hot flushes. Thank you, madam.
Thank you, Joe. And it's nice to be chaired by a person who is same year passing as you. So I will just share my. There is a shared thing, yeah. Share my. Yes, so thank you, Archana, for inviting me to speak along with so many stalwarts here. And it was lovely. I really learned from Jyoti's and Sudha's talk, in spite of having spoken about those topics for so many times. We learn something every day, I think. So today I've got a nice topic only to talk on Tibolo, nothing else. And so it's so simple. Yeah. You know what? Just Sudha said that in 1942, the estrogen molecule came. That was a quit India movement going on, and then abroad people were talking of estrogen that was started to be marketed when we were fighting the British here. But after using it for many years, they realize there's a lot of bleeding, and so you have to stop it. And somewhere in the 60s, they added progesterone to stop the bleeding. And what happened to the progesterone? We need to not stimulate the endometrium, because this progesterone, it stimulates the breast. We know that the increase in breast cancer risk that came from the progesterone, not from the estrogen. So you need a drug that won't stimulate the endometrium. You need a drug that will not stimulate the breast. And it is tissue specific to do all that estrogen does. And so in 1964, they searched. They worked on rats, hamster eggs, and somewhere in 64, that idea of Tibolon came. But it took them 25 years later. They must be all Buddha by then. And by then, in 89, we started extracting Tibolon and its hormonal profile determinants. Even then, they were trying to look at the Tibolon action on heart, Tibolon action on brain, breast, bone, one by one, and finally, somewhere, how to calculate the dose. That was done 18 years later, somewhere in 2000 to 2007, to find the dose. And the concept that it is a selective tissue estrogenic activity regulator, that was done in 2004. So where are we now in 2024? It is a weak steroid, and the minute it goes into the liver, it gets hydrolyzed into estrogen, progesterone, and androgen. Basically, the estrogen part will act on the alpha and the delta isomers and the and on the alpha and beta isomers, and the androgen will go and bind to the delta isomers. So that is how Tibolon can get hydrolyzed into all three. So, you need to give progesterone, and you have one more, plus you have an androgenic effect in addition. So it will reduce hot flashing and sweating. That's the basic thing. But it will also reduce bone resorption. These are the key things that we look for in MHT. And you don't need to put other, or when you give MHT, normally if you have genitourinary syndrome, you need to give your vaginal estrogen. But in Tibolon, it does improve the karyopycnotic index in the vagina, and it reduces the atrophy and the dryness and everything in the vagina. In addition, the androgenic effect, it can improve the mood because of endorphin, and libido because of the androgenic effect. It can improve sleep. It prevents loss of muscles. So every time the older faculties get onto the stage, they need someone to catch them because their muscles are gone, their magnesium is gone. So if such people are taking Tibolon, they can jump onto stages faster. It improves the lean body mass, decreases the proliferation in the breast epithelium. So if you have dense breasts, it is better to take Tibolon than the estrogen and progesterone. And it induces endometrial atrophy. Forget stimulation, it can induce endometrial atrophy by its progesterogenic action on the alpha and the beta receptors and the delta receptors, like what I said earlier. What it does is, it causes a decrease in the triglycerides, lipoprotein, and LDL. But it does lower the level of the high density lipoprotein instead of raising it. That's why they were wondering what will happen to the cardiovascular system. So they were fighting. Really didn't come to a conclusion. Some people say it is good for the cardiovascular system. Some people say no. We are really skeptic whether it is cardioprotective. Like how we say that in estrogen MHT, if you give it in the window period, and for hot flashes only you give it, but then you will die. You will not die of heart attack if you are taking the estrogen on the pretext of having hot flashes, because it is cardioprotective, although it cannot be given for that indication. But the same thing for Tibolon, we are not really very sure. I know Sudha is looking at me. She's written a whole chapter on this. She's read more chapters on Tibolon than me. I have quoted her in my slides somewhere. I have read her article also. She has written in JMH for this. So there is a decrease in fibrinogen and factor 7 activity, increase in thrombin 3, plasminogen, and overall trend towards increase in fibrinolytic activity. So we do not know the status of cardiovascular protection. That is there. So what? We can always go on exercise and everything. No? So many other things are there to protect your heart. The dose is 2.5 milligram per day for hot flashes. Actually, if this dose, the hot flashes will be going. They have even tried 1.25 ka dose, but that it will improve your sexual things and all much faster. But hot flashes will take a little longer time to act. The other things will act faster. So what are the studies? Actually, there are studies where they compared tibolone with estrogen, progesterone, and it actually has got, they found some effect and everything's best found to be better than estrogen. This is a final thing. Earlier, I'm not a researcher, but the earlier they found that it was better than estrogen was better. Then after doing statistical analysis, finally, tibolone was supposed to be better. Unscheduled 27 with another study. So actually, no, bleeding is less with tibolone, although you can't call it a bleed-free totally, but it is lesser compared to the HRT. But some of my patients, they take the HRT, they are very happy. Doctor, I'm getting my period. So then, oh God, what do I do now? Should I put you on vanilla vaccine and all that? No, I'm very happy. I love my bleeding. I get my periods. I don't have hot flashes and I'm very happy. I'm a great woman. So there are people who love their bleeding also. So you really don't have to think that bleeding is something that patients don't like. But tibolone, even it does have a progesterogenic content that we all know. In women with history of breast cancer, we always think, so many of them really have real bad hot flashes, and we think, oh, then can I give tibolone? Because it's after all not estrogen, it's after all not progesterone. No, but it does contain estrogen and progesterone, and it has Liberate trial and Stockholm trial. All of them have said that in women with history of breast cancer, it is not to be given. And one thing is breast density events like mastalgia are reduced. I had a patient with, who was on local estrogen for 2 years. She never informed me only. And then afterwards, she got mastalgia. She went to a surgeon and she got a mammogram done because she was scared. But it was all because even the local estrogen was causing mastalgia. So when they come with mastalgia, you have to reduce the estrogen level. But in tibolone, this breast density events like mastalgia are in fact reduced, and you don't have to worry about that. And in a patient with, whenever these patients come with breast pain, we always say, go and get your mammogram done. I want to make sure you don't have a problem. But if a patient with a dense breast comes and she's on HRT, the mammogram won't be very good because you have to stop the HRT for 4 weeks and then redo the mammogram. So that may, that patient gets so upset, oh God, what happened to me? In tibolone, you don't have to do that. It doesn't affect the breast density, and you can do a mammogram immediately if she's got a problem with her breast. And it is the drug of choice in women with dense breast. So you can do a mammogram, does not affect it. So that's one thing good about tibolone. People who are smart, they say that bleeding occurs in the first 1 year. The bleeding stops after the 1 year. So start tibolone after 1 year of menopause. That's what the pundits are saying. But I really are asking them, if their patient has got hot flashes in the first year, how can you start it after 1 year? She's got a problem at that point of time. If you want to reduce the chance of abnormal bleeding, yes, it makes sense to start it 1 year after menopause when the bleeding time is less, is gone, at least. If the bleeding does occur, so there has totally explained everything, endometrium 9, endometrium 8, blah, blah, and everything. But if then the tibolone, if the endometrium is more than or equal to 5, maybe you can do this thing, biopsy or something. Otherwise, it doesn't really matter. Yeah, we all think that after 60, the gray zone is over. So women who read upon menopause after 60 and come to you for MHT, you cannot ask them to take MHT. But even in tibolone, you can't do that. So it has to be used in caution in women with more than 60 years of age. It has to be used in caution in women with history of stroke. It's not that it's not estrogen, so it's all easy for patients without, it may decrease the body fat. Of course, it's not the best way of dieting. It increase the fat-free mass and total body water. But weight gain should not be a major concern among users. Progesterone, we all know it causes waterlogging, and it does increase, the blouses become tighter when you're putting them on drugs for DUB or even your progesterone in pregnancy and all. But even though the body water is increasing, weight gain should not be a major concern in Tibelon. Yeah, when symptoms like insomnia, nervousness, disinterest, fatigue, and loss of concentration, all this, it's called androgen deficit syndrome. Tibelon can be a good option. It is superior to conventional hormone therapy in surgical menopause, especially in endometriosis patients where you have to give estrogen plus progesterone, because endometriotic implants are estrogenic, and if you don't give progesterone, they will get, if they are there even after hysterectomy, it will get this thing. But if you have done that, that practically is the only place where you remove both the ovaries. There, Tibelon is a good option, and it is in fact superior to conventional HT. And sexuality changes, I already told you, it is better than conventional HT. So, finally, Tibelon is a good alternative to estrogen and hot flashes. Conditions where estrogen is contraindicated, however, quite often apply to Tibelon also. Androgenic actions of Tibelon gives added benefit and androgen deficit syndrome. Incidence of bleeding is lesser. Women with dense breasts may benefit better with Tibelon. It may be used as an add-back therapy when you are giving GnRH analogs for, you have VMS with that. And you can maintain the BMD when you give your endometriosis or fibroid treatment or whatever. Tibelon should not be used in breast cancer survivors as it increases recurrence risk. It does reduce the risk of breast cancer in postmenopausal women. Tibelon may be used in women with myoma and endometriosis. It is significantly greater improvements in sexual interest in more than transdermal, and contraindicated in pregnancy, undiagnosed vaginal bleeding, severe liver disorders, thromboembolic diseases, and some lipid disorders. Thank you so much.
So you're
Thank you.
muted. So you're muted.
Harish sir, you're
Oh,
muted.
you're muted.
Okay. Thank you, Madam Subna, for nicely covering your topic. All points were very well taken off. I have personally used in my colleagues' medical fields, right, 10 years back when I was of that menopausal age, and they were very happy with Tibolol, right? Not
Okay.
only it causes mood changes and all that insomnia part, because at that time of life, right, 40, 50, 45, the
Yeah.
other social reasons are also there, apart from hormonal deficiency, which causes the disturbance in their mood changes as well as insomnia and other part. So Tibolon was wonderful drug for that time, but I always prescribed for very short time, 6 months. And as you mentioned clearly that only breast cancer, history of breast cancer is the contraindication. Otherwise, you can prescribe to each right of the woman, and particularly those who have contraindication to hormonal therapy, that is estrogen therapy. And that is very important. And the drug, and you have mentioned the Cochrane review also regarding the bleeding, that is less than as compared to hormonal therapy, right? And that mammography, dense breast tissue also, HI hormone therapy is on mammogram, you have to stop for 4 weeks. Here it is not required. So wonderfully covered, madam. Thank you, madam. Thank you, Subna, madam.
Thank you. Thank you.
Thank you so
Jyoti,
much.
I think you can give it to up to 4-5 years. We do not have, I didn't find any data where there's a problem. HRT we are giving for 5 years without breast cancer. I think the same thing we can, mostly like Harish sir said, after 6 months, who will take it? They will maximally, when you are giving it for hot flashes, 2 or 3 years is enough. But Tibelon, you can take it for long. There is no ceiling on how long you can take Tibelon.
Okay, I have not thanked the organizers. I must thank the Foxy and ICOG top office bearers and chief convener and conveners and coordinators, all Archana and Archana, thank you for inviting me, all other people at the right main backstage. Thank you very much.
Here, thank you all the organizers.
Thank you so much, Harish, sir, for chairing the session and giving your expert comment. And our speakers, Dr. Jyoti Jaiswal, Dr. Sudha Sharma, and Dr. Shobna Mohandas for their wonderful, very informative lectures. Now, I would request my colleague, Dr. Priya Thakur, to continue with the session too.
Thank you. Yeah, am I audible?
Yes,
Yes.
yes.
Yeah. Can I request the tech team to give me the next two chairpersons' biodatas, Dr. Kiran Pandey and Professor Bharti
Okay.
Maheshwari?
I'm sharing. I'm sharing.
Yeah. Yeah, so without delay, I would like to invite for the next session Dr. Kiran Pandey, and she's chairperson, Medical Education Committee, FOXY. She's an ICOG Governing Council member 2023 to 25, reviewer of the Journal of Obstetrics and Gynec 21 to 23, and president of Kanpur Menopause Society. And she has a lot of achievements to her credit. Welcome, madam. And can I request you to share Dr. Bharti Maheshwari. She's a professor and head of Department of OBGY and IVF in Muzaffarnagar Medical College. And she's a chairperson of FOXY MTP Committee 2018 and 2020, fellow of ICOG AIFOG, and joint secretary of Uttar Pradesh, UPCOG, vice president Merit Obstetrics and Gynec Society, and she's an author and editor of many textbooks of OBGY. Welcome, madam. Would I request you all to please introduce our speakers for this session and take over the session, please?
Thank you. Thank you very much. And the outset, I am thankful to the organizers for giving this opportunity. And our first speaker of the second session is Dr. Hari Subramaniam. Dr. Hari Subramaniam is Mayo Vivan Fellowship 2023 NHS Leadership Academy. He's honorary professor, Department of Health Sciences in the Montfort University, Deputy Medical Director, Lancashire Partnership NHS Trust, consultant psychiatrist for the elderly, a very, very well-known person, medico-legal expert, and health assessor and supervisor, consultant psychiatrist and consultant old age psychiatrist at St. Matthew Healthcare. He will be talking on the mental health in the menopause, which is a very, very important thing and often most neglected part, or where the people do not understand unless and until. So it's very, very important to understand what are the issues and how to deal with it. So I welcome our speaker, Dr. Hari Subramaniam.
Thank you very much, madam. And my thanks to the ICOG and the esteemed faculties. I'm just sort of checking that I'm audible.
Yes, sir.
Okay. And yeah, thank you very much for this opportunity. I think I'm grateful that I've got this chance to be able to speak. I'm trying to share my screen. Is that possible? Are you able to see it?
Yes, sir.
Okay.
It is visible, sir.
Thank you. Thank you very much. So, I mean, I think there's quite a lot of history and stigma related to some of the issues surrounding menopause. And if we go back into the history of how this has come about, I mean, I think the word hysteria and mental health sort of problems is related to the word hysteris, and which sort of translates back to the uterus. And so historically, there's been a lot of negative connotations about the hormonal imbalances and the psychiatric disturbances, perhaps that happen to women around this sort of age. So I think there is quite a lot of negative connotations. And so what we want to do is to try and take a bit of a more balanced view on what the real sort of situation is like. So I think quite a lot of menopausal symptoms have been described in literature, and quite commonly the issues reported are depression, irritability, lack of confidence, poor concentration, and so on. I mean, these are some of the symptoms, but as has been previously described, they're not very specific symptoms. There's quite a lot of overlap with a number of other medication or iatrogenic related symptoms, but also overlap with physical health problems such as anemia and other sort of chronic health conditions. Then there was an attempt to try and standardize it a bit more. And so we've got the menopausal index scale. It was an 11-item scale and describes a number of vasomotor symptoms, paresthesia, insomnia, nervousness, melancholia, and quite a lot of overlapping symptoms. But again, none of these are very specific. But there is an increasing recognition. There's quite a lot of symptoms which come around the time of menopause. So what is the psychiatric sort of view? At one point, it was thought that menopause has got a high risk of development of mood symptoms and psychiatric disorders. But if you do a systematic review of literature, it doesn't seem to be the case. I mean, it's not necessarily any clear evidence that there's a higher incidence of psychiatric syndromes or mood sort of symptoms or anxiety disorders in and around menopause. And historically, there were terms which were described as involutional melancholia and involutional psychosis. That does not appear to be the case any longer. What does seem to be the case is there is an increased level of psychotic depressions and some degree of what we would call as paraphrenia, so late onset psychosis. That happens. But that happens to women at that sort of age as much as it happens to men at that age. But it's not necessarily related directly to the hormonal imbalances or in any way directly to the menopause. Psychiatrists see many women with psychiatric disorders. Only a few of them are menopausal. And I suppose this is a typical bias in terms of studies and perhaps in terms of research and in a more methodological way when you try and look at it. Whereas more gynecologists will be seeing menopausal women, and quite a lot of menopausal women would seem to have a number of psychiatric symptoms. So it might, on the face of it, seem that there is an increased level of anxiety disorders and so on. But when you look at systematic evidence from community studies, this does not appear to be the case. If anything, women in the postmenopausal years actually show some lower evidence of psychiatric disturbances than perhaps younger women. And in a way, you can scientifically understand the more number of hormonal sort of ups and downs that you get, there are higher chances of mood and affective disturbances during the normal reproductive cycle, whereas actually once the menopausal years set in, perhaps that degree of fluctuations is not as common. But there are a number of physiological changes and psychoanalytical and cultural sort of changes that affect and social changes that affects a woman's vulnerability to a psychiatric disorder. So as we sort of alluded to just now, quite a lot of hormonal and endocrinal changes, and there are fluctuations in sort of hormones like prolactin, cortisol, thyroid hormones in particular can be a problem for women around this age, and obviously hypothyroidism itself can present with a number of mood and psychiatric disturbances. So there may be some overlaps with TSH levels and triiodothyronine as being the causal or etiological sort of factors. What we do see, though, is that there is an increased psychiatric morbidity in women around the age of 45 to 50. And this is not sort of directly related to the menopause, but that seems to be the particular age in which there's a higher range of psychiatric morbidity. And in a minute, we will look at why those reasons might be. But also there's psychoanalytical sort of way of understanding it. And there are symbolic significances of perhaps a feeling of loss of femininity, loss of reproductive potential, perhaps the feeling of emptiness, maybe purposeless existence, and of course, quite a number of worries about fear of not being attractive anymore. And so these sorts of things can cause anxiety and loss of self-esteem. Plus, of course, there will be sort of changes in terms of libido and sexuality, and that itself can create a degree of feeling of inadequacy and psychological sort of changes. More importantly, there are sort of significant cultural, social, and family factors. And this all seemed to coincide around that time between 40s and 50s, where women probably struggle, they're more likely to cope because there are major changes in their body, but not necessarily changes in the body, but also changes in terms of their structure of family, changes in their life structures, and perhaps even a degree of change in their work and employment status. So a lot of women perhaps at that time are thinking of reducing work. They probably are thinking in terms of having to have more care or responsibilities, looking at aging parents, perhaps looking after husbands with other physical health problems. And so there is a lot of other pressures that will come to bear upon women at this age. And this is in the context of a society where aging is seen quite negatively, and there is a lot of emphasis on the sort of value of being youthful. And you look at any television advert and it tells you that you need to be young and good looking. And so there's quite a lot of pressure from from the society, and also more so in this modern day with various social medias. So there's quite a emphasis on looks and appearance, and that can place a degree of sort of peer pressure and perhaps self-pressure more than anything else. But in terms of culturally, there can be varying different sort of views. So I suppose in the West, sometimes we see women at the age of 40 and around 40, 50, around the time of menopause, but it's not directly related to menopause. But these are the times when perhaps women have more marital disturbances, perhaps difficulties with families, divorce, children, adolescent children, and that can cause increased propensity to affective symptoms. Paradoxically, I think there is some evidence that maybe in societies like Indian societies, the social standing of some older women might actually increase after menopause because there is a degree of feeling of freedom and self-esteem, and not necessarily having some of the negative taboo and connotations of perhaps the younger women during their reproductive ages. But the effects of children leaving home, marrying, emptiness syndrome, those sorts of things can also play a part. What seems to be the case is women who report that a child has got married or left home more recently, around the time of their sort of menopause, are more likely to show some degree of psychiatric disturbances. But again, as we said, the associations are more likely to be social and cultural. And there is a general perception about their own future as individuals rather than being somebody else's mother. And plus, the issues of returning to work, education, or training after perhaps the family having grown up and moved out. So there is something about meaningful employment and gainful employment in trying to keep oneself busy. So readjustment in terms of marital relationships, poor marital relationships, all these things can affect the psychiatric sort of disturbances. So more than menopausans, in a way, the major influences of risk of developing any affective and anxiety and depressive symptoms at this time are really about worries of work, ailing husbands, aging parents, care or responsibilities, adolescent children, some degree of interpersonal relationships between families. Those sorts of things can have a greater influence than just menopause alone. In terms of psychological morbidity, what we see is that there's a small increase in psychological morbidity, but this is not necessarily in terms of psychiatric illness, but this actually precedes the natural menopause and after the surgical menopause. So I think there's a slight difference between natural menopause and surgical menopause in the way the psychiatric sort of symptoms arise in response to these events. And again, as we talked, social, psychosocial, and hormonal factors may be quite relevant. Psychosocial symptoms, there's generally sort of a belief that hormone replacement therapy may work, but actually the evidence is that any replacement therapies is probably not that effective unless it's a surgical menopause. If it's a surgical menopause, then there is some improvement in psychosocial symptoms with estrogens, but not in terms of natural sort of menopause. And where sexual symptoms are present, then there is more consistent evidence that hormone replacement therapy is effective. What about treatment? Yeah, so in treatment, I mean, I think as we said, hormone replacement therapy itself will not sort of alleviate mood and anxiety symptoms. Depression and anxiety sort of does not really respond to estrogen replacement therapy and responds to more conventional treatments, like conventional antidepressant treatment or anti-anxiety treatments and psychosocial approaches. More often than not, a standard sort of SSRI type treatment is likely to be more appropriate. The things that perhaps need to be thought about in terms of treating these symptoms is in the first line is usually an SSRI in situations like this. Drugs like citalopram, sertraline, they're all sort of equally effective, and there is no evidence that one is superior than the other. Drugs like fluoxetine tend to be long-standing and can interfere with some of the other medications. Sertraline perhaps is slightly better insofar as it doesn't interact with other medications that may be present. So a SSRI would seem a reasonably good choice. And what they sort of say is that if it doesn't work within the first sort of what is initiation dose, then it's unlikely to work with subsequent increased doses too. Some caution with using drugs like mirtazapine and venlafaxine only because while they're effective, they can also add more to weight and might sort of paradoxically cause some weight gain and thereby knock confidence. And I think drugs like tricyclics, etc., should be last line resort and should probably be done only after the other conventional antidepressive treatments are tried. There's some evidence that insomnia may respond to estrogen, but there is no evidence that estrogen improves memory or cognitive functioning. There is quite a lot of belief that actually HRT might improve memory and cognition, but actually the evidence is not consistent with this. Estrogen may be useful for dyspareunia, which may be associated with vaginal atrophy, but actually there's no clear role in its being able to treat any sexual drives or libidinal sort of changes. So I'm going to just wrap up and then allow some sort of discussions and questions. So contrary to popular belief, the physiological changes of menopause have less impact on mental health. If at all, there is a fall in the actual minor psychiatric disorders in the decade following menopause. There is a suggestion of a slight increase in the perimenopausal period, much more between 40 to 50. And there is some slight increase in the prevalence of psychiatric disorders in the 5 years immediately preceding menopause. More often than not, there are life events such as changes in family structure, parental sort of caring responsibilities, problems in family structures, work-related sort of issues, and generally psychological reappraisal of future roles that may have an impact on mental health. And this will respond better to supportive and psychological approaches. But in situations where there are some affective symptoms, then something like a first-line treatment with SSRIs would generally be very effective. So I will conclude with that. There are some MCQs that I've given along with the presentation, but that can be looked at a different time. I am going to stop sharing if I can work out how to do it.
Thank you, Dr. Subramanian. It was
Was that all right? Okay. Can you hear me
Thank
still?
you. Yeah, we can hear you. It was a wonderful talk and focusing on the different aspects of the mental health of the menopause woman. And the very specific point which you said has to be remembered, that it's not like other factors, like we have been discussing the previous scenarios. Here, HRT or MHT does not give any specific benefit unless and until it's a surgical menopause. So more important is the family support, as we all know, and the pressures. The counseling to avoid all those pressures, and support from the family members, their understanding of the problem, why this is happening. And if not, counseling and the psychotherapy doesn't work, then SSRIs is the standard treatment. That's the basic thing. So if anyone has any question, and if organizers do permit or otherwise, we can proceed to the second talk. Yes. Hello.
Ma'am, please introduce Dr. Shobha Goody, ma'am, for the next
Okay.
talk.
Okay. So let's move ahead to the next talk. I'm Dr. by Dr. Shobha Guri. And we all know her here very well. She's president of BSO, BISOG, and she has been executive member of Kasoga also. She's chairperson, family welfare committee, Foxy, very active person. And she's still secretary of the Bangalore Menopause Society. And she has been assessor of the GOI project Laksh. She's board member of FPAI, peer reviewer of Jogi, elected GCM ICOG, executive member of Fox, Kasoga, and distinguished DNB teacher. Lots of work for her. So Dr. Shobha Gudi is going to talk uh, about the other aspect of MHT, non-hormonal. So Dr. Shobha, are you there? Hello, Dr. Shobha.
She was there, ma'am.
Hello.
Yeah, she was there.
I'm here.
Yeah,
I'm here.
yeah.
I'm here, Kiran. Am I audible?
Yes, now you are audible. So
Am
welcome. And please,
Am I audible?
your
Yes,
network
ma'am.
is
Yes, ma'am.
very unsteady. You are audible, but it is
Yeah.
not so good. Anyway,
Yeah. Thank you, Kiran, for the kind introduction. And after that excellent talk by. Okay, just a minute. Huh? Okay, now is it better?
yeah, presently.
Mm-hmm. What shall I do?
You
Shall I
proceed.
proceed or
Let's
no?
see.
Yeah. So my problem, it's better, I think. Is it better now? No?
Yes, ma'am.
At,
Fine.
Archana, can I start sharing
at the
Yes,
screen?
ma'am.
moment,
Yes, ma'am.
you are
Please.
audible clearly.
Okay. Let me share screen and see. My problem is the computer audio is not working. So I'm speaking through the mobile, but I'm sharing the screen on the computer.
Oh,
Okay, so they have disabled participant screen here. Please enable me to share screen. Some circus I have to do. Share screen, please. Yeah,
Yes,
got
ma'am.
it. Yeah, got it. Is my screen visible?
yes,
Yes,
make
ma'am.
it full screen.
Yeah. So is it okay now?
Yes,
Yes, ma'am.
Okay.
perfect.
Can I proceed? Okay.
Yeah.
Fine. Let me know if the audio becomes shaky, Kiran. Huh? Okay. So thank you, Kiran, for that introduction. And my talk is on non-oral MHT. Uh, what I thought that I should not bring in too much of theory about the drugs because enough has been spoken over the past 3 days. So I should directly see how we can enable prescriptions after this, certification course. So I'll be speaking only about the clinical context, not much about the drug also. So please focus. So the World Health Organization today clearly says that the life expectancy for women is 85 years and plus on an average, even in the LMIC countries. So that includes us right now. And women's health and the quality of life after menopause is becoming increasingly relevant. That I think all of us as practitioners agree that almost 40% of women walking into our clinic are actually midlife and above. And when they come, we try to screen them for the symptoms of menopause as shown and which has been spoken and deliberated all over the past 2 days. So first we have to check on the history about the symptoms because the basic tenets of menopause hormone therapy, as Dr. Sudha Sharma, Jyoti, and also Dr. Shobhana, everybody clearly said today that it is mainly driven by the symptomatology. So the most effective treatment of the vasomotor and the GSM is menopause hormone therapy. There is no doubt about it. And it is also effective in preventing osteoporosis. MHT is effective therapy. It is safe for women less than 60 years or those who are within 10 years of menopause. It should not be used in undiagnosed vaginal bleeding, estrogen dependent tumors, breast cancer, active thromboembolism, active liver disease, and gallbladder disease that also we know. And then the symptoms of menopause will vary very widely. So many practitioners feel that Indian women actually do not have many symptoms and they do not require MHT, but we are wrong because the symptoms are unexplored and understated and not expressed by women. They are driven by the individual's physical, mental, social, cultural, and racial features. Therefore, highly individualized menopause consultation is required, examination is required before MHT is, and that is the driving force for tailor-made menopause hormone therapy. So we come to the specific indications for non-oral or transdermal estrogens. There are two indications in which non-oral therapy is required. One is the systemic MHT, which is delivered by transdermal estrogens, and very kind of upcoming is the combination of estrogen and progesterone. I won't be talking about that today, neither about the progesterone patch nor about the testosterone patch. I want to focus only on estrogen. And the second one is the vaginal estrogen, which has already been covered, but I'll just touch it in passing. So all women needing systemic MHT are actually eligible for transdermal estrogen. But it depends on individual preference. It depends on affordability because this molecule is slightly more expensive. Hypertension with variable BP control, this is a specific indication for transdermal estrogen. Diabetes mellitus is relative. Yes, if they are on too many drugs and they are having comorbidities for cardiovascular risk, transdermal is preferable. If there is a known cardiovascular risk, if there is past or family history of venous thromboembolism, they are better off with transdermal. That we should not deny them estrogen. We should prefer transdermal. If they're obese, if they have migraine, especially with aura, if they have gallbladder disease, suppose the oral therapy fails, try transdermal before giving up on MHT. If there is poor absorption due to GI intolerance, again transdermal. If there is hypertriglyceridemia, then transdermal, but not the other dyslipidemia, because women with LDL high and cholesterol high will still benefit with oral estrogens. Non-thrombophilias, okay, if they are there, factor V laden or even APLA may be candidates for transdermal. We come to the GSM, where also topical and systemic MHT also may be indicated in them, in addition to topical if they are having VMS, vasomotor symptoms. So topical plus transdermal also can be tried in such women. Now, atrophy is caused by changes in bladder, urethra, vagina, and genitalia. Why I brought this up? Because this is one indication where non-oral route of MHT for several years may be required. More research has to go into safety data for this kind of therapy. Why I brought it up here is because VMS as a symptom will not last for the entire geriatric lifetime of the woman. It stops after a few years, but GSM is progressive and it's likely to require treatment for a very long period of time, probably for the lifetime of the woman. That is why I brought it up. Topical estrogen is recommended for the treatment of GSM and recurrent UTIs. That everyone has understood in the past 2 days. Now, the treatment of VMS will require systemic ET, and this will be effective for treating vaginal atrophy, but not effective for treating UTI. So if you use systemic MHT, like transdermal or oral, it will cover vaginal atrophy to some extent, but the urinary symptoms will not get covered. For that, you do require the transvaginal estrogen. Non-estrogen therapies should be complementary therapies here, which Jyoti spoke about. Lubricants, vaginal moistures, local ospemifene is non-oral hormone, which has been tried, not available in India. Vaginal DHEA has been tried, and laser therapy also she spoke about. I brought this up all because this will add to the treatment of, but nothing can replace vaginal estrogen, the non-oral MHT, if for vaginal atrophy, okay, and the urinary symptoms. Now, let us talk about enabling prescriptions for non-oral MHT. And I thought that I will get some of the formulations, but unfortunately, Indian formularies do not have these products, or I was not able to find them. So I picked it up from NHS, and you can see the plethora of hormones available. Similarly, we also have. Let me just show you one or two of them which we also have. For example, we have patches, no, we have vaginal, we have oral tablets of estradiol 1 milligram here. We have patches, but they are not currently available. We have in the second, I think I should go, this one. Here we have, of course, LNG IUD as the local form of progesterone. We have um, vaginal tablets, we have vaginal pessaries, we have vaginal gels actually, and vaginal cream. Preberin is a vaginal cream. Okay, we have estriol creams, and we also have the one which is available for us is the spray, which I'll come to now. This is the local estrogen formulary in the NHS, and it shows us the vaginal cream, the vaginal gel, and some of this is available also in India. The estriol gel and the estradiol cream is available in India. Okay. So when we come to HRT formulary, the transdermal options, uterus, if it is present, then continuous combined, when no bleeding is required, then continuous combined. If bleeding is required, then you give cyclical. But then all these women can also have the transdermal estrogen if required. Okay. So estrogen only is needed. This is the basic tenet of which I wanted to show. Okay, so here when we talk about transdermal, we can see that there are patches. Can you see this box here? Patches. Then we can have estradiol. We also have Proginova as the oral, and we have the Lenzetto spray. The Lenzetto spray is the one, the transdermal spray, which is currently available in India. And we need to familiarize ourselves with it, and we need to bring it into practice. I think it is useful for our women, though the cost is at present slightly higher. So this is the HRT guide from the BMS, the British Menopause Society, which shows the vaginal estrogen preparations. We have similar preparations in our armamentarium also. And this is a similar declaration of the benefit versus risks. This is a slide which I wanted to focus on. And here we see that the transdermal, whenever the woman requires HRT, she can be offered either oral or transdermal, is what I wanted to emphasize. And in the transdermal, we have a variety in which we have the spray today, and we have the gel, and we also have the cream. Okay. So here there are direct indications for transdermal therapy, individual preference. If she has for transdermal, if she has poor symptom control with oral, GI disorder, previous or family history of VTE, if she is obese, variable blood pressure control, migraine, current use of hepatic inducing enzymes medication like anti-epileptic and gallbladder disease. A slight repetition there. Just one thing is, when do we need to refer to secondary care? Or in other ways, I can say, when can we shift from oral to transdermal? Perhaps maybe when there are persistent side effects, when there is a complex medical history, when there are bleeding problems with sequential and continuous combined HRT, maybe transdermal will be better, or along with a progesterone device in the uterus like the LNG IUS. So this is how the Lenzetto looks, the transdermal spray, and it has that no declaration that it will control hot flashes, the night discomfort, even palpitation, the local symptoms, the sleep problems, and the mood swings. Okay, and they say that there is by week 12 there is very good reduction of hot flashes, and by 6 months there's an 82% reduction of hot flashes. It is an actuated transdermal spray which contains 1.53 milligram of estradiol for the treatment of symptoms, and it is quite effective. Now let us kind of familiarize ourselves with the pros and cons for transdermal versus oral, so that we become a little smarter in choosing our patients. The baseline risk of VTA and stroke is very low in otherwise healthy young postmenopausal women, those who do not have any high risk factors. So let us not be too worried about VTE and stroke if we have taken a good history and we have ruled out high risk factors. Therefore, if a patient prefers oral over a transdermal, cost or personal preference, then oral estrogen also is safe. But then we must prefer 17 beta estradiol versus conjugated estrogen. For example, oral estrogens should be avoided in hypertriglyceridemias. Okay. And I also spoke about thrombophilias and past history of VTE. Transdermal is also preferred for women with migraine. I spoke about this. Now, oral estrogen has more favorable effect on lipid profile. HDL raises with oral estrogen, LDL decreases, and there is perhaps a long-term clinical benefit. Oral estrogen increases SHBG more than transdermal, decreases the free testosterone, and therefore is there a negative impact on libido? But this will not happen with transdermal. This will not happen. Oral estrogen anyway increases triglycerides, increases thyroid binding globulin. So whether this impacts hypothyroid women because it decreases T4, increases cortisol binding globulin and total serum cortisol. Clinical relevance of that is yet to be determined. Well, there are some questions still unanswered despite various routes. And in the history of breast cancer, non-oral MHT also will not solve the problem. The alternatives are less effective. There's limited evidence from RCT. Safety and effectiveness of non-hormonal treatments like ospemifene, CEA-BZA or local vaginal estrogen for menopausal symptoms in women after treatment for breast cancer. So it is not that local vaginal estrogen has not been used in such women. It has been used for short period of time when there is history of breast cancer, but we are not sure about the results, and RCT large cohort studies are needed, which will establish difference in breast cancer recurrence, mortality, and tumor aggression. So this is very complex clinical field, and therefore this question remains unanswered for now. In the basic tenets of MHT, therefore, which estrogen is it necessary? Have we decided? What dose for how long is progesterone needed? Which one? And the parallel care is essential. Again, this is telling us what are all the available formulations of topical estrogen, transdermal topical gels, intravaginal creams, etc. Estrogen MHT lower than in POI HRT. That is why we have to be careful about choosing the dose. When there is primary ovarian insufficiency, they require higher dose. For treating VMS, systemic estrogen, oral or transdermal, both are effective. Okay, so oral estrogen essentially undergoes the hepatic metabolism, which is the first pass effect, increases the hepatic production of all these globulins which I spoke about, including the triglycerides and the HDL. One is negative impact, one is positive impact. It causes increased cholesterol, clotting factors, and cholesterol in bile. But only all this effect is only very minimal by transdermal estrogen. So transdermal estrogen is as effective as oral for VMS and is safer. Transdermal estrogen has lower risk of VTE and stroke and less effect on serum lipids. All right, so dose equivalence we need to know. Okay, dose equivalence we need to know. Oral 0.625 conjugated equine estrogen, oral 1 milligram micronized 17 beta is equivalent to 50 to 100 microgram per day of transdermal 17 beta estradiol. This is what we need to remember. And estradiol gels and sprays are available in different strength, and always be sure of what dose it is being delivered. So today we have in India the skin spray, Lenzetto, as I spoke, that is by Themis. That is the marketed preparation available. It is available that delivers 1.53 milligram of estradiol with each spray. Now, one caveat or one caution is the topical estrogen spray will tend to remain in the skin, and by contact with children and pets, it can transfer to them. And it can cause absorption through the skin for them. It can cause changes in the breast, etc. So one has to be very careful. Maybe women should learn to use full sleeves. Okay, I'm
Sorry to
finishing
interrupt,
now.
ma'am.
Yeah, I'm finishing now. So can we use transdermal estradiol low dose without progesterone in women with intact uterus? The power of transdermal is reflected in this one study, and the level of evidence one has been generated with transdermal without estrogen in 417 women. There was no endometrial hypoplasia. I would like to finish with these few slides of Dr. Peter Greenhouse, who is a crusader for transdermal estrogen. And he says that the bottom line is that MHT lowers all-cause mortality, and that 4 times higher risk of DVT is there with oral than with transdermal. And of course, he also says that it is important to give hormone replacement therapy at the correct time. In menopausal transition, also, in addition to COC's low dose, transdermal estrogen, along with LNG IUS, has a high role to play, and probably more research can be directed in this direction, where we can address the window of opportunity with this medication. In conclusion, a knowledge gap among some general practitioners and other healthcare professionals could mean that they are reluctant to prescribe HRT because they overestimate the risk and contraindication and underestimate the impact of menopausal symptom on a woman's quality of life. Non-oral MHT is a treatment modality which is safest and will hopefully become more cost-effective in the future. Thank you for a patient listening.
Thank you, Dr. Shobha. As usual, you have been very crisp, very precise, and a very practical points you have given. What should be you written and what should not be written, where, when. So everything is very nicely covered. I don't think it needs further elaboration at all.
Thank you, Kiran. Thank you.
Really, it was a very crisp and good talk. Points to be noted by every postgraduate. So I think so. It's the time we go for a third talk by Dr. Malaraj. May I have the CV? So Dr. Malaraj is an endoscopic surgeon, fertility specialist, aesthetic gynecologist, managing director of the hospital, Firm Hospital, Chennai. And he will be talking about the vaginal wall prolapse. Actually, we all know the vaginal wall prolapse. To some extent, of course, there are inherent defects also, congenital tissue weakness also. But many a time when we are dealing with the prolapse management, probably we are not taking the right supports, the adequate supports, which should be taken, taking the time, and do not take proud into doing it in a short time, but it is a better one. As a surgeon, I would always like to take all the supports so that the vaginal wall prolapse is not created. That's the basic thing. I'm sure Dr. Mala will be telling the different aspects, how to manage it laparoscopically, endoscopically, and maybe it is abdominal sacropexy, but whatever she would like to throw light upon it. So, Dr. Mala, the floor, the dais is yours.
So, good evening, everybody. Thank you so much, Kiran Madam, for the warm introduction. At the outset, I would like to thank ICOG for giving me this wonderful opportunity. I had to step in place of Dr. Parul Kotadawala, sir. Of course, it is extremely difficult, but then I will try my best and hope I do justice. So, as beautifully Kiran Pandey Madam quoted, apical prolapse, of course, the most important crux of this prolapse is that prevention. So it is ideally better to prevent this from happening rather than treating it. Apical vaginal prolapse is considered, support is considered as a keystone organ support. Although apical vaginal prolapse is frequent of all the POP types, ranging from only 5 to 15%. So prevention is always better than cure. So during hysterectomy, we need to make sure that we take care of the adequate support of the vault by incorporating the pubocervical fascia and the rectovaginal fascia at the vaginal cuff intraoperatively. And also we need to make sure that we attach the uterosacral ligament to the vault. And also another third important point is that we have to identify and correct any intrusion that may be present at that time, because this again will lead to vault prolapse in future. So POP is a very common problem affecting almost 50% of the Paris women, and 6 to 20% of them will somehow undergo surgical treatment for these prolapse at least by the age of 80, because we are having a very aged population which is in the current scenario. So the next, why women are developing prolapse. This is a very long run debate whether it is the muscle or the connective tissue. That is what is constantly a debate, but one needs to understand that it is not just the muscle or the connective tissue, it is they both, which results in the prolapse, not only just in the other types of prolapse like first degree, second degree, third degree, but also it is essential for the muscles to also to be really strong for us to prevent the development of the vault prolapse. So how levator ani really support the pelvic floor is also mandatory, because once the levator ani is lax, the introitus become loosened, the intra-abdominal content kind of comes out to the posterior to the exterior, and as a result the pressure in the anterior and the posterior compartment is equal and balanced and cancelling out each other. So as a result the women kind of develops prolapse if there is any weakening of the pubocervical, rectovaginal or the uterosacral ligament support. So that is the reason why we need to make sure that we are not only correcting the suspending the vault, but we also need to identify if there is any muscular weakness, and we need to correct that as well at the time of the hysterectomy. So Delancey has very beautifully demonstrated the normal pelvic support, that is the interaction between the levator ani muscles and the connective tissues, which helps in stabilizing the vagina at various level. And this is mainly demonstrated beautifully at various level defect. So it also necessary that we need to understand why cystocele develops. It is not just about the damage and the ligament failure, but it is a combined one which results in the cystocele also development, and also muscle levator ani muscle injury and prolapse. Of course, as I mentioned, this is very vital in all these women. We need to ensure that the levator ani muscle also, laxity also is taken care at the time of repair of the prolapse. And the line of action also we need to understand is that in the standing position, the cardinal ligaments are relatively in a vertical orientation in the upright posture. That is quite logical, but the uterosacral ligament are more dorsally and it is directed towards the sacrum in an orientation where it can prevent the uterus and the upper vagina from sliding down the inclined plane of the levator plane. So the cardinal and the uterosacral ligament change their length and angle in response to the pressure, and it is applied to the pelvic organs during increase in intra-abdominal pressure. So it is also found that it is the length of the ligament rather than the laxity of the ligament which is essential for the development of the prolapse. And of course, these are the various level of defect demonstrated by the Delancey, which all of us are familiar about. Of course, the level 1, we have to make sure that the cardinal and the uterosacral ligament are well taken care. Of course, that is what is mainly essential to prevent the development of the vault prolapse, which is of interest to us in this particular presentation. And of course, level 2 and level 3, we are not going to focus. But we need to understand that level. It is not that the patient has just any one level defect. The moment she has a defect, that all the other components are also going to be weak. So we need to be aware of that. Whereas where in level 2, it is only the pubocervical fascia, the rectovaginal fascia getting attached to the arcus tendinous, and that kind of gets disconnected. And of course, level 3, as I mentioned, it is a urogenital hiatus and the levator ani muscles. So this has been beautifully quantification of the POPQ, which has been now helpful for us to understand the various degree of prolapse, because it is, though it may be clinically very difficult for us, but then it is necessary when it comes for the research purposes, where we need to grade the prolapse and treat them accordingly. So level 2, level 3 and level supports of the uterus, which I have already highlighted. And here what we need to understand, as I mentioned, it is just attachment, suspension and fusion, and all the 3 levels are continuous and interdependent on each other. You cannot just get a single defect, because over a period of time all the 3 components would be affected. So the structural integrity is very vital, and this is the vital vault prolapse and the POCU quantification. You can see the BA is -3 and C, that is the vault, which is +2.5, which comes below outside the introitus. And these are the way by which we can quantify the prolapse based on POPQ. So what step we need to take at hysterectomy to prevent the development of prolapse? As I mentioned, prevention is always better than cure. So once excision of the uterosacral or the cardinal ligament complex during hysterectomy, we need to make sure that you put them back to the vault. So suture the uterosacral ligament or the cardinal ligament back to the uterus, and also incorporate the pubocervical fascia and the rectovaginal fascia again to the vault, thereby helping to prevent the vault prolapse in the future. And this as and also the most important step, as I mentioned earlier, we have to identify whether there is any enterocyl. So if there is an enterocyl, you have to rectify it, either if you are going to do it vaginally by mecal caldoplasty, or if you are going to do laparoscopically, Moskowitz technique, where you need to obliterate this sac so that you do not develop vault prolapse in the future. So these are the re-establishing the suspension of the pubocervical and the rectovaginal fascia at the vaginal vault, which is a very, very vital step for us to prevent this development of vault prolapse. So here is a small little video which you can see that how we suspend the vault to the uterosacral ligament during TLH procedure. So here the first and most important, you can see how the uterosacral ligament is be incorporated in the vault while suturing the vault. So the first and most important, take a bite in the uterosacral ligament and then on the vault, and then you can suture it however you want, either continuous or intermittent. But that step of incorporating the uterosacral ligament is very vital. And of course, here in a TLH, we generally do not separate too much of the rectovaginal fascia unless and until it is needed. So obviously, it will be incorporated in the vault. So you have the that is a basic advantage with TLH, because all these structures are quite visible and you can beautifully identify them and incorporate in whatever defect is there. We can make sure that you can incorporate all of them and correct at a single instance, so that you can prevent the future vault prolapse development. So this is a basic thing which one needs to do at the time of TLH to prevent a future vault prolapse. Sometimes you see that you can also plicate the uterosacral ligament. If you feel there is some kind of an laxity while suturing the vault, you can just take plicate the uterosacral ligament a little bit and then attach it to the vault. In that manner, you can again give some support to the vault and anchor it to the uterosacral ligament in a better manner and prevent the development of the vault prolapse. So while doing so, it is mandatory that you have to separate the ureter a little bit. So here you can see that I have separated the uterosacral ligament from the ureter so that there is no traction on the ureter and you are able to do the procedure without causing any damage to the ureter as such. So the relationship between the uterosacral ligament, the ureters and the rectum also one needs to identify. It can be done vaginally also, but the only thing is laparoscopy has its advantage because you're able to see these structures so beautifully and you can know where exactly the ureters are and you can do an ureterolysis, and these are the landmarks and the distance of the ureters from the uterosacral ligament. As we go above, you can see the ureters is about 1.3 to 2 centimeter lateral to the uterosacral ligament, and this we need to keep it in mind whichever method we are employing to suspend the uterosacral ligament to the vault. And the features of the uterosacral ligament have also been studied, and they have found that there is a varying amount of connective tissue, smooth muscle fibers, and the neurovascular structures along its end. And the thickness of the uterosacral ligament also have been analyzed. So we use the uterosacral ligament to the maximum to support the vault. So we should understand that the uterosacral ligament does not have any kind of a bony attachment. So it proximally it is inserted only to the tissues in the S2 and S4 region. So we need to start high uterosacral ligament suspension for a better vault support. And also if you see the thickness of the uterosacral ligament is also varying. So it is maximum thick at the mid portion, which we need also keep it in mind. And when we do an uterosacral ligament suspension vaginally, these are the points that we need to keep in mind. That is the optimal location of suture placement is sometimes at the level of the ischial spine when they do it vaginally. And this is how we use the barb suture to close the vault. And again, in the same, whether we use barb sutures or the smooth sutures, the most important step is that you have to incorporate the uterosacral ligament and suspend the vault. So, so if the apical support is not given, the vault prolapses, and then we have to do the procedure or suspending the vault. Either you can suspend it to the anterior longitudinal ligament, that is at the level of the sacral promontory, which was earlier considered as the gold standard for the wall prolapse. But now we find that the pectopexy is supposed to be a very beautiful procedure because it does not have any of the backs of the sacrocolpopexy. And also the problems associated, again, sacrospinous fixation also can be done vaginally to prevent the wall prolapse. But here the problem is that when you do it vaginally, you generally fix it to one of the spines. So there is a deviation or to of the angle of the vagina to one side. And as a result, the axis of the vagina is disturbed, and you can see that the patient develops a defect on the opposite side. And also the depth of the vagina is also compromised. So that is the reason now the laparoscopic approach is found to be much better. And we tend to do a pectopexy where we use a iliopectineal ligament for anchoring the vault, because it is found to be much stronger. It holds the suture well, and you have sufficient platform for us to anchor the wall to that of the ligament. And also it is at the level of the S2 vertebra, this which is found to be the physiological axis of the vagina. So that is the reason why this laparoscopic pectopexy is found to be a better option rather than sacrocolpopexy. So here you can see that now the lateral vaginal wall is being opened. So the point where exactly we open is that the triangular area between the round ligament and the median umbilical ligament we need to open. So ideally it is just lateral to the median umbilical ligament that we need to keep in mind. Most of the people, they find it difficult to identify the spot, but then I tell them that just open lateral to the median umbilical ligament in the triangular area, because it is just the continuation of pubic symphysis, the pubic tubercle, and then you have this pectineal ligament. You can beautifully palpate it. So it is not at all a very difficult procedure, very simple procedure. Just open that peritoneum. But only thing is you have to be careful about the vital structures. You have the external iliac vessels there. So once you open that, you will see a white glistening structure, which is the lighthouse of the peritoneum. That is the lighthouse of the pelvis. That is the iliopectineal ligament. So and once you identify the iliopectineal ligament, then we need to anchor the mesh, attach the mesh to the iliopectineal ligament, wherein you use a non-absorbable suture like the ethibond. Here you can see that I'm using an ethibond to anchor the mesh to the iliopectineal ligament. Always use a macroporous mesh so that there is no mesh erosion or infection. So once the mesh is anchored to the iliopectineal ligament, then you can anchor it to the vault. So this is done, and then once you anchor that, then you can, so this is a case to prevent vault prolapse. I had done this because she had some amount of laxity. This is done. So which ligament is thicker, iliopectineal or the anterior longitudinal ligament? It has been found that the iliopectineal ligament is found to be much better than the anterior longitudinal ligament, because it is when they use taco, the landmark of the iliopectineal ligament is that you have the external iliac vessels and the obturator nerve, and this was studied on the cadaver, where the external iliac vessels was about 1.04 to 1.25 centimeters, and the obturator canal was 3.13 to 3.57 centimeters below the iliopectineal ligament. So we need to make sure that we take care of these while doing this particular procedure. So this is the pectopexy. Here you can see that the tacker, you can also use tacker if you're finding it difficult to use the if you're finding it difficult to use the take sutures, you can use tackers and then fix it to the vault to prevent the wall prolapse. So once you fix it to the wall prolapse, then you can finally you can just close the peritoneum over.
Ma'am, your time is up.
Okay, fine. Just 1 minute. So this is Moskowitz technique where you have to also incorporate make sure that the introsil is also corrected. So here you can see that the ureters are dissected and the recto-vaginal, you can see that the pouch is being obliterated and the vault is being closed. So these are the ways by which we can suspend the vault to prevent vault prolapse. And of course, the vault prolapse, we have the most important step is that we need to make sure that we take adequate precautions to prevent rather than treating this. So pectopexy would be a better option in case of vault prolapse. Thank you. So,
Ma'am, please, chairpersons, please give your expert comments. Kiran, ma'am.
Then
So
should we conclude this session?
Yes, I think we should move to the next session.
Okay. So we would like to thank the chairpersons for this session, Dr. Kiran Pandey, Dr. Bharti Maheshwari, and the speakers for this session, Dr. Hari Subramaniam, Dr. Shobha Gudi Madam, Dr. Mala Raj. And with this, we can move on to the panel discussion. Archana, if I could request you to share the CV of Dr. Pratibha Singh, please.
Sure.
Yeah. Till Archana is sharing, thank you everybody. All the speakers did well justice to the topics and thoroughly it was very encouraging and thank you Mala
Actually,
for
I'm not
roping in
able
the
to
last.
share.
Okay.
I don't know. I'm not able to share.
Pratibha ma'am, you can share as a first
Thank
slide.
ನೀ ಬಂದ್ರೆ ಹೇಳ್ತೀನಿ
Just.
ವಿದ್ಯಾಪೀಠ ಹತ್ರ ಹೋಗೋಣ ಬಾ
Yeah.
Okay.
Shobha,
Please mute yourself.
I would like to invite our moderator for the panel discussion, Professor Dr. Pratibha Singh. She's a consultant laparoscopic gynecologist and IVF specialist and director of Healing Touch Hospital, Bhagalpur. She's chairperson, Fertility and Aging Committee, IMS 23 to 24, President, Bhagalpur Menopause Society, and she has a lot of presentations, publications to her credit, and indeed, she'll do a wonderful justice to the panel. Madam, I would request you if you can invite all the panelists for this discussion.
Ma'am,
Dr.
should I
Pratibha
share the
Singh.
panelist or will you be sharing? Pratibha ma'am is there?
Actually, let Pratibha ma'am unmute herself, please. And even Shobha madam wants to be unmuted.
Yes.
Please.
Hello, can you hear me?
Yes, madam.
Okay.
Yes, ma'am.
Can you please invite the panelists?
Yeah, I'll be inviting.
Yeah, thank you.
Can you see my slides?
Yes.
Is it full screen?
Yes. No, ma'am.
You'll have to make it in a slideshow mode.
It's not inside slideshow, no? Oh. Now it is in slideshow?
Yes,
Dr. Reshmi is not able to unmute herself. Please make her co-host.
It's in slideshow, I think. Yeah, I can see.
Okay. Can you see, no? Yes.
Yes.
So good evening, everyone. And first of all, I would like to thank the ICOG team, especially Dr. Parul, Dr. Sarita Madam, Dr. Parag Binewala, Dr. Chamila, and all coordinators, Dr. Archana, Dr. Geeta, Dr. Shobha Madam, for giving me this opportunity to moderate this very important panel. So first of all, I will just invite all our panelists. So we have our first panelist is Dr. Rajendra Nagarkatti. Is he there? Sir, are you there? He is the past chair for midlife committee.
I'll call
I
him,
cannot
ma'am.
see him actually.
I'll call him. You continue, ma'am.
Okay. Our next panelist is Dr. Priya Vora. So she is the Vice President, Mumbai Menopause Society. She is also the MOG's Managing Council member since 10 years. She is also the Youth Council mentor since 6 years. And she has been contributed many chapters, received many prizes. And she is also the peer reviewer of Jogi. So welcome, Dr. Priya. Our next panelist is Dr. Archana Singh. She is the director of Siddhi Vinayak Hospital, Haldwani, Uttarakhand. And she is the founder secretary of Uttarakhand Society of Obstetrician and Gynecologist. She is also the state secretary, North India Gynecologist Forum. She is also the scientific secretary, IMA Haldwani, and past secretary, Haldwani Obs Gynae Society. So welcome, Dr. Archana Singh. Are you there, Dr. Archana?
Yes, ma'am. Thank you, ma'am.
And another panelist is our own Dr. Reshmi Banerjee. I cannot see her, Reshmi.
Yeah, she's there,
So
ma'am.
she is
She's
the
there.
secretary of Baroda Afghani Society. She's there?
Yeah,
She is
yeah,
also
yeah.
the national
She's there, ma'am.
chairperson for CSR Committee, Indian Menopause Society for 23-25, organizing secretary, WWW Conference Vadodara 2024, and which we really enjoyed. Just few days back, it was we had an opportunity to go to Vadodara. So wonderful hospitality and wonderful program. She is also the life member of IMA, Foxy, ISAR, and IMS, and very active member of Foxy as well as of IMS. So welcome, Dr. Reshmi. And our next panelist is Dr. Madhumita. She is consultant obstetrician and gynecologist and reproductive medicine from Salem. She is the treasurer for Salem chapter of TEP ISAR and executive member of OGSOS. She is also the ISAR Youth Brigade Council member, peer reviewer of Jogi, and she has a recipient of MS Foxy 2023 Award, Foxy Superstar Award 2019, and 4 international publication on ART to her credit. So welcome, Dr. Madhumita.
Thank you
So
so
with
much.
this, we'll start our panel. Now, for women to live long, menopause is inevitable. And I think with the advancement in the field of medicine, now the life expectancy is increasing. So even for the females, the life is increasing. So almost 30 years of her life, women usually spend in postmenopause. And what data says that by 2025, there will be over 1 billion women expecting menopause in the world. And it will be around 12% of the entire world population. And in India, if you see, more than 130 million women will be in the transition through menopause. About 5.5% of women in India are suffering in is the data which has been shown. So now she's not alone. And also the size of the problem is not that small. When we were doing our PGs in 90s, I think menopause was just one chapter. And mostly we just used to read, and I don't think so many questions also used to come from that. But now the scenario has already changed, and now menopause has become a very important aspect of female life, and we should take care of the female when she reaches in her menopause. So menopause has a lot of she has a lot of problems like personal, professional, psychological, as well as physical. So during menopause, about 45% of women, they struggle at work. About 33%, they feel that their social life has taken a back. Then about 51% feel sex is not on her menu. And about 81% have low BMD. So they have backaches, pain in legs, and all those problems. And about there is two times increase in the risk of CVDs. So these are the data. And with this, we will start our panel on menopausal health. So actually, this question was for Dr. Rajan. So Anybody can take this question if they want. Priya, if you want to take, you can take.
Yeah, sir has excused. He's into mid of some emergency. He'll join. In the meantime, if required, Dr. Shobha Gudi madam is there.
Okay,
myself
so
is there.
Shobha madam, if you can take this question.
No, let Priya answer, madam. You have said once, so let Priya answer. No problem.
Yeah, Priya, okay. Priya. So
Yeah.
this is, she's a woman with premature menopause, not requiring contraception. Would you prefer conventional HRT or use OC pills? And what are the difference between the two?
So, madam, in premature menopause, these patients definitely do need estrogen, some form of replacement therapy. And it is shown by evidence that rather than no treatment, you have to give estrogen to protect the bone, to protect the cardiovascular risk, like to reduce the risk of that. So they do need.
Hello, can you hear me?
Hello,
Can
am
you
I
hear me?
audible? Hello.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yes.
And here you can give them until the expected date of menopause, you can give them combined estrogen with progesterone in the younger lots. Contraceptive pills also they
No,
can
no,
be
this
given.
patient, she doesn't need contraception. This patient, she doesn't need, she has already been sterilized. So do you want to
Yeah.
still continue
No.
with the contraceptive pills, or
But in cases, the recent evidence
we
does
will
show
be
that
giving
for in
HRT
a
in this patient?
premature menopause, the conventional MHT will be superior for the bone health in compared to the combined OC pills. So again, even according to the British
Yes.
Menopause Society and all the latest guidelines does show that it is more superior to give a MHT which is safer in these patients because they are more physiological rather than the synthetic OC pills, and the lumbar spine has a better BMD, giving the MHT.
Okay. Okay. Correct. You have already said everything, that bone mineralization and the metabolic effect, that is more favorable with MHT. Okay. Now, this is again for you, Priya. This is 41-year-old asymptomatic female getting slightly prolonged periods for 3 to 5 by 40 to 50 days and wants to know what medication to take to avoid this problem of menopause. So
here, madam, it's important for us to counsel such patients.
Yes.
Basically, there is, so it is a physiological process. It's a very natural process. So not everyone is really going to have problems with menopause. First, this part needs to be told to the patients. And only so there's nothing like we can really take any medication, but we need to lay emphasis on a correct lifestyle, eating healthy diet, doing a proper physical activity, exercising, taking good amount of supplements like calcium and vitamin D. And then only if there are, so most of them sail through the menopause properly. It's important to counsel these patients that not everyone really needs
she feels that,
therapy.
I mean, do you think that it is a symptom for her? Like menopause, she is
Yeah.
having irregular periods. So she says, I am having some problems. So do you think it is a problem? I mean,
So
how you are going to
irregulars,
counsel this patient? What are you going to tell?
so we need to basically exclude the other causes of a irregular scanty period. But in this case, it
Yes.
can be, so
Yes.
you need to keep in mind that when there is a perimenopausal woman, I mean, it could be a surrogate marker, anovulatory cycles, because there is a decline in the estrogen, there is a rising FSH, and there are anovulatory
Yes.
cycles. So it can be one of the surrogate markers for an irregular, a perimenopause.
Yeah. Okay. And what are the general investigation needed to do at this age? I mean, if the patient comes to you, so what all tests you are going to do? Just basic test, what you are going to do.
Good evening, ma'am. So in this case, we need to know that midlife is a phase when there are increased burden of the NCDs. So here we are more at
Yeah.
risk of various cancers and metabolic syndromes. So we have to do some screening tests. We have to go for a hemogram. Then we have to look into we should go for a clinical breast examination, and if the doctor suggests, you could go for a mammogram. A pap smear and a HPV DNA should be done.
Do you
And
think that mammography should not be done? I mean, only if there is
yes,
some
ma'am,
problem.
she's 41. It should be done. She's 41 because we start at the age of 40. And then the cardiovascular screening
And
has to be done by
then
hyperlipidemia, a BP check, Then you should know the blood sugar levels of this patient, also the thyroid profile.
Yes. Okay. And for bone also, if you want to see, you can go for some.
DEXA scan is not routinely done, but
But
if she
what
has
can
some
you
risk
do?
factors
PFD
for
can be done in this
osteoporosis,
patient.
because she is 41 years, ma'am, right now we don't know she is having her periods because of perimenopause, or because this is an early menopause coming in, or it is because of some other factors. So we just rule out the other factors, and we know that this is a perimenopause coming in, then we should do a DEXA scan because she is going into an early menopause.
Okay. So now she has a doubt that is it a menopause? So how are you going to confirm, or how are you going to counsel her, or what you are going to tell her? That she
So
says that
first,
to go for some test or something should be done, so that
definitely, ma'am, because she is
I
just
come to know
41
that
years
she's
old.
reaching to menopause.
First, I will
So how are you going
first I will
to
rule
clear her
out
doubts?
other causes. First, I will rule out other causes of delayed cycles, because she is
Yes.
hardly 10 to 20 days overdue, delaying her cycles. Although she appears to be in the -2 phase of menopausal transition, but then also we have to confirm other causes also. So if other causes are fine, and then we need to rule out menopause, then yes. Although other tests are not needed if she has a
You
delayed
don't need to
cycle,
do
but
any
because
test to confirm that she has it.
ma'am, we can do, because here there are no other symptoms coming up. She only has delayed cycles. So if
Okay.
she is in doubt and she wants to confirm, then we can go for an FSH test.
Okay. Now this was for Reshmi. Is she there?
Yes, ma'am.
Yes, ma'am.
So hello Reshmi. So this is for you, that she wants, but still she wants prescription
Yeah, so I mean,
for estrogen,
estrogen has
because
also
somebody
been
has told her
marketed as
that she has read in Femina that estrogen is
yeah,
a mother harm. So what are
yeah.
you
So
going to
estrogen.
advise? How are you going to
So
counsel her
in the social
regarding her
media,
lifestyle, diet?
there are a lot of articles saying that estrogen is a wonder hormone. It will keep you young and the skin supple and everything. But see, we need to counsel her that not all women will require hormone replacement therapy, and there are other alternative methods also in which she can, dietary methods are there to ameliorate her symptoms. So first of all, we'll have to make her
So what do you
aware of
think
her
in the diet?
supplements.
How you are going to
Uh,
counsel this patient?
Diet may, so see, first of all, she need to take adequate calcium, vitamin D, and adequate proteins, all trace elements, iron if she has anemia and all that. So she has to take a proper diet which has all the ingredients in the proper proportions.
So do
So
you
like
think
I
that
said,
only balanced diet will help her, or you need to add something to her?
if she does not have any, if she is not symptomatic for menopause, she may not be given supplements, or we can only give her
Hello.
like alternative therapy or herbal supplements. We may not give her hormones. Hormones are not,
Yes,
hormone
not
replacement
harm.
therapy is not always necessary if a
No, I'm
patient is
talking
not
about the
symptomatic.
diet for
Yeah,
supplements. Yeah.
diet may, yeah, she can take a balanced diet and I mean, all she should include all ingredients in a diet.
Okay.
But diet rich in calcium and proteins is definitely needed.
Yeah, so that diet which has
What
adequate
about her
dietary
exercise?
calcium, proteins, vitamin X.
Yes, yes.
As far as exercise, see, a sedentary lifestyle is
Can
an
I'm not able
biggest
to hear your voice actually.
Aisa?
Voice, I'm not.
Madam, now can you hear me?
No, I'm not able to. Hello. Can you hear me? My voice is there.
Yes, ma'am, your voice is there. Can others hear me?
Yes, ma'am, we can hear. Actually, we can hear both of you clearly.
Hello?
Hello.
Yes, ma'am.
Yeah.
Yeah, so
Okay.
sedentary lifestyle is the greatest enemy for us. So patient has to be physically active, especially weight bearing exercise, a
Now what
body weight bearing
all exercise or whatever?
So weight bearing exercise she should be doing mainly, and weight bearing her like her using her own body weight bearing exercises should be there. There should be some resistance training, and even routine household work can also help, maintaining a small joints flexibility and mobility. So all sorts of so like we said, walking, cycling, non-weight bearing exercises, then swimming, yoga, use of resistance bands, dumbbells, all will help, because you will also develop muscle strength, which will help her to prevent from sarcopenia later on in life.
Okay. Now this question is for Dr. Madhumita.
Yes, ma'am.
Dr. Madhumita.
So would you offer MHT to one and all menopausal women who come to your OPD? So it is not just that we offer MHT to all menopausal women, ma'am. Basically, we decide upon with what symptoms actually the patient comes with. Basically, when she comes with frustrating menopausal symptoms like especially vasomotor complaints, like moderate to severe vasomotor complaints, or especially if she comes with the genitourinary syndrome of menopause, or also in case of when we want to prevent osteoporosis. In these patients, definitely we have to give MHT. And as discussed, any patient who comes with premature menopause, these are also candidates for whom we have to give MHT. And then as it's always preferable to, the earlier you start, the less than 5 years we start, the better. So any patients with even like vaginal dryness, dyspareunia, or mild symptoms, even incontinence symptoms. So these symptoms all constitute, they come under the bracket of genitourinary syndrome of menopause. So these we take into account. And also like other, if she's struggling with vasomotor symptoms, with these patients, really MHT really, it gives them a fresh lease. So they're really comfortable once we start MHT. So these are the patients that we specifically we give. And also in case if the patient just comes and we think that she's at a higher risk for osteoporosis, especially patients like if she's a smoker, any family history of early onset of osteoarthritis. So all, and suppose if she's very like her BMI is very less. So these patients, we for the prevention, even though she's asymptomatic, though at present she doesn't have any specific complaints, any specific postmenopausal symptoms, but then in order to prevent further any osteoporosis, and in order to prevent osteopenia, to keep her healthy, we give.
Okay. Okay. So
Yes.
now, normally, if the patient is asymptomatic, you usually don't need MHT, but you must always see the risk assessment for the disease. Then only you should start prescribing MHT to this patient. Now, this is a question for you. Hello, yeah. This is 48-year-old school teacher, para 2, living 2, last childbirth 12 years back, not ligated, and her having irregular scanty flow every 3 to 4 months, and is experiencing severe hot flushes and night sweat that disrupt her sleep, and her performance at work is on toss. She also is having mood swings, which is affecting her relationship with her colleagues. Otherwise, there is no significant family or personal history, and she has also tried lifestyle changes but has no relief. Now, what is your diagnosis in this case? So, anybody can take this question. This is for
She is
Dr.
in the
Raj.
late perimenopausal phase, minus one phase of the menopausal transition.
So she is for the climateric, in the late perimenopause.
And she's symptomatic, so she is almost moderate to severe
how can you
VMS.
define that? It is the time.
Because she is having hot flushes with night sweats and disturbing her sleep. So this comes under moderate VMS, vasomotor symptoms. So she is symptomatic for this, and because she also has irregular scanty periods, so she would really definitely benefit from MHT. It can also help regularize her cycles and will relieve her symptoms. And also we should explain to her regarding sleep hygiene.
Yes. So this is, you have correctly said everything. Now, any laboratory test to confirm this diagnosis? We have just now we have said that all these tests, she has just now enumerated one of our panelists. But do you think that diagnosis of the following without any laboratory test can be done?
We'll not need laboratory tests to diagnose menopause, but we may need to rule out other causes like thyroid disorder should be ruled out, and whether she is hypertensive, whether she is, so the test would be required as a pre-MHT workup and not to diagnose menopause, and also to rule out other diseases like thyroid disorders and angina, maybe cardiovascular system, which also can mimic the symptoms of menopause. So we need to do tests to rule out those things, the other diseases.
Yeah, definitely. We should not be doing all these tests. This is not required in these patients because we have seen many prescriptions where patient comes with all these tests. Doesn't rule out that she is in menopause. Now, only FSH can be done to diagnose menopause in the cases where the woman is aged between 40 to 45 years with menopause and those where you are suspecting premature ovarian insufficiency. In that cases, you can do, and that is also related to her fertility. If you want to, if she want
Yeah,
trying for pregnancy or something. So okay.
definitely.
Now this is for Priya. What treatment you are going to offer for this patient, this particular patient?
So I think, as we've already said, that she has VMS and which is quite moderate. So she will require sequential MHT, and we can give the newer preparations which are
Yeah.
there, which have estradiol, 17 beta estradiol, 1 milligram by 10 milligram of dydrogesterone. You have to give a sequential therapy, and if yeah, and combined OC pills can be used also, but
Yes.
preferably sequential or combined OC pills.
What
Any
about
of
any
this can be altered.
yeah, any other alternative therapy if she is asking, I mean, if she feels that that can be given to her?
So we can give Madam phytoestrogens, that is
So these are the
isoflavone or
complementary
lignans.
therapies,
They are
phytoestrogen, non-hormonal
available.
drugs, and lifestyle.
Yeah,
We can.
non-hormonal medications also like clonidine or anti-epileptic drugs like gabapentin, venlafaxine, desvenlafaxine, like FSRIs and SNRIs can be given. And otherwise, even
What is your
botanicals.
takeaway for phytoestrogens? What do you think that phytoestrogen should be given?
No.
I mean, it can be given. Is there any
But
evidence
in
based?
her case, I think we can counsel her since she has moderate to severe hot flashes. We can try with isoflavone for short time. But if it's not going to be beneficial, then we will have to go into the estrogen replacement or sequential MHT.
Yeah, because this is nice guidelines which says that these are the, I mean, these are the drugs. Normally, they have not been approved properly by the guidelines. So normally they are not given because many a times there is interaction with other medicines are
And even
also
liver
reported with this.
toxicity is
And
reported with
different
black
preparation may
cohosh.
vary different. Yeah, yeah. So that is what. So this is also Royal College of Obstetrics. They have also given this statement that the efficacy continues to be lower than with traditional HRT. The trials on alternative on the whole remain small and short duration, and therefore the data is very limited for its efficacy and safety. And also, without they are these alternatives are not without their any other adverse effects and risks. So that is why if you are giving non-hormonal drugs, you have already enumerated. So these are the non-hormonal drugs which can be used. And what about the lifestyle changes? You have few things.
So you need to tell her to wear cotton clothes, layering of the clothes, and sit in the cooler environment like the air conditioned fans, then cold baths, and avoid the triggering factors like spicy food, alcohol, smoking, then even these exercise,
Yes. And what
meditation,
about
relaxation, yoga, all these things may help.
taking coffee in the nights?
Yeah,
I mean, that also
they
can
need to avoid caffeine also.
yeah, foods in there. Anyway, now what about the contraception? This is for Dr. Archana.
Yes, ma'am. Ma'am, in this case, I would like to recommend contraception in this phase because there might be spontaneous ovulation occurring and unintended pregnancies might occur.
When do you think
And
what is the age of menopause in
ma'am, it
in
is
Indian
46.2 years as per the guidelines in India. And after the final menstrual period, 12 months after the final menstrual period, unintended pregnancies might occur if you're not taking any type of contraception. So
Yes.
this period should be covered with contraception, and contraception will give you an added advantage to alive from some risk factors like the carcinomas, breast cancer, and then cardiovascular risk factors, ovarian carcinoma. So, therefore, I would like to give contraception in this case. And I think
Now,
any type of
why it is
contraception can be given if no
yeah.
comorbidity is there.
Yes, yes. Okay. And what about your take home for this LNG IUS? Can it also be tried?
LNGIUs can be given, ma'am. This is a quite a very nice contraception. If there are no other factors and she just needs a
So that should be
contraception,
kept in mind because many a times patient, and if there is some bleeding problem also, that can also be
that
solved
can
with
also
this.
be taken. Yes, ma'am.
Now this is for Reshmi. A 42-year-old woman presented with symptom early menopause, including irregular periods, hot flushes, and night sweat. She is concerned about her bone health since her mother had osteoporosis. So, what does early menopause effects of on the bone health?
Yeah, so early menopause will affect bone health because
Hello,
there are early menopause will definitely affect bone health because she has that many less years of exposure to estrogen, number one. Number two, the maximum loss of bone density is seen in the couple of years prior to onset of menopause and 1 or 2 years after the onset of menopause. Like 2 to 4% of bone loss per year is seen. So definitely she should be concerned about her bone health, and MHT has definite proven role in prevention in maintaining BMD in improving the bone mineral densitometry. So she should be counseled for the same. And regarding the diagnostic test, yeah. So regarding the diagnostics test, so because since she's 42 years old, and if she we'll have to do her there are scoring systems available of so according to that we should
You
do the
tell them what is
scoring
the
system.
osteoporosis
Yeah, so there are a couple of scoring systems available. One is OSTA, which is
assessment,
the
and what is
easiest.
the calculators available? And
Yeah, so the calculus of the simplest and the easiest is OSTA, which only takes a weight of the patient and age of the patient into consideration. For that, we don't need any sort of investigations. It can be done in any setup, even in the rural setup, and it is quite. And there are charts available in which mild, moderate, and severe it can be. We can categorize them, and depending on that, if it is mild, you can just give them calcium, B12, D3 and lifestyle modifications along with exercise and everything. Moderate will require hormone replacement therapy, and in severe you will have to also add maybe bisphosphonates and other advanced treatment. Then second which is available is FRAX, which is country specific. It is an online scoring system. In that also it is available with BMD and without BMD. So even DEXA scan is not necessary. It is not compulsory to do a DEXA scan before starting MHT. So FRAX score is available with BMD and without BMD, which will give us a 20-year risk of major fractures and also hip fractures. If it is more than 20% and or hip fracture more than 3%, then the patient has to be put on MHT. In that, because since her mother had osteoporosis, but whether she has history of fragile fractures is not mentioned, so that will also have to be taken into consideration along with addictions like smoking, alcohol, use of glucocorticoids, and various other factors are there. So these scoring systems can be used. We can categorize the patient on mild, moderate, and severe, and then the specific treatment can be given according to recommendation.
But still, the DEXA score is considered as the gold standard.
Yes.
But it is not necessary. See, if it is severe osteoporosis, then DEXA score can be done as a baseline and can be repeated not before 1 year to see the response to treatment. But it is not compulsory before starting treatment. Yeah, if you're putting a patient on anti-resorptive therapy, then DEXA score or bone marker should be done to know the response to treatment. But to start MHT, according to recommendations, but if she's a young with a major risk factor, like now we'll be mentioning, then there are recommendations to do a DEXA scan, but it is not like not doing because I don't have access to DEXA scan or the patient cannot afford a DEXA scan is not an excuse to not start MHT. What is the recommendation?
Because DEXA scan is not available in all cities. So
yeah, so not doing a DEXA scan is, or patient cannot afford or it is not available, is not an excuse to not start MHT. That is the recommendations by all the guidelines.
Now,
so
the major risk factor.
So the major, like I mentioned, if there is a major risk factor, they are like the advancing age is of course a single most significant risk factor according to the, in addition to being the female gender, then the low BMI, so less than 18, prior history of a fracture, parental history of a hip fracture, smoking, alcohol, smoking is more than 1 pack per day, alcohol more than 3 units or 90 ml per day, use of glucocorticoids for more than 3 months. Here I have specific use of systemic glucocorticoids and history of rheumatoid arthritis.
Okay.
And in the parental history of hip fracture also, if it is mother or father, that also has a scoring system in the FRAC score.
Okay. Now this question is for Madhumita. Now she is hypothyroid, but it is well controlled. Now weight is 68 kgs, BMI is 27.9, and she is a daily drugs, no any past history of fracture, and her osteoarthritis is so nicely, and Varex without BMD is 2.3 and hip fracture 0.9. So would you advise her to go for BMD in this patient?
Ma'am, as such,
or what are the indications for BMD?
Ma'am, for BMD, postmenopausal women above 50 years old, if she can get it done, if she's affordable, it is better that we get it done. So
because it is available everywhere, I think.
Yes. So any postmenopausal woman more than 50 years, or even if
in
it's
every
less than
places
50
we can do.
years,
In camps
any
also we are
other
taking
risk factors. Yes, ma'am. So even if less than 50 years old with any other risk factors, and in this smoking is a very important risk factor here. Though her FRAC score seems to be in low risk case, here she's a daily smoker. So that is a very important risk factor. So definitely I think, and so she comes under, so she's more prone to develop osteoporosis. So it's better that if she is, she can access BMD, it's better that she gets it done. And also regarding the other indications.
What risk factor, what category?
Yes, ma'am. Here in her FRAC score, actually for this patient, her FRAC score, the MOF and the hip fracture risk both had been in low risk here.
So what category she falls in? Which risk group she falls in?
Yes, ma'am.
Which risk category of risk?
Regarding the FRAC score, she fell under low risk, not under high risk category. According to the FRAC score here. So basically, suppose in case if it is a low risk, she must not have had any previous fractures. Yes, ma'am. If it's a low risk case, the probability of fracture, that is any major osteoporotic fracture, that is any major that is MOF, it should be less than 20%, and hip fracture risk should be less than 3%. These are the two important factors that we take take into consideration. And suppose if it is less than this given cutoff, then the 10-year probability of fracture due to osteopenia and osteoporosis is said to be low risk. Suppose in case if it is more than 20%, that is a major osteoporotic fracture, and hip fracture is more than 3%, the 10-year risk is said to be higher. And also in the BMD, we take into account the DEXA-derived T-score. If it is between -1 and 2.5, it is under low risk, and if it is less than 2.5, -2.5, that is we take it under high risk. So what is to be done in case of low risk patients? Encourage healthy lifestyle, good diet habits to avoid smoking, alcohol, and also just see that her calcium intake and vitamin D intake is good. In case of higher risk patient, they have to be monitored more closely. Again, the same very good lifestyle is of utmost importance, and then again start appropriate treatment to prevent bone reabsorption so that she doesn't progress.
Yes. So anything else anybody wants to add? Reshmi, you want to add something in this?
Yeah, if there is a high risk factor and to know the follow-up prognosis, whether there is an increase in the BMD, definitely DEXA should be done. But for the initial assessment and in low risk patients, I still, according to the guidelines, I would still say that BMD is not a compulsory investigation. DEXA scan is not a compulsory investigation.
DEXA, no? Not BMD, no?
Not BMD, sorry. The DEXA scan is not a compulsory investigation
Yes,
in a
that
low risk patient.
So
but to know the prognosis of the therapy, whether the patient is responding to the therapy, the DEXA scan can be repeated after should be repeated after 1 year to know the response to therapy, especially with anti-resorptive therapy.
what preventive measures we have already discussed many things. So this is so Reshmi, can you take this?
Yes,
what preventive measures you can have to protect bone health? Yeah, we have already said all these things.
Most of the things have already been said.
And about the lifestyle modification, calcium, vitamin D. So first of all, you have to counsel the patient to limit alcohol intake to more than 2 units per day. This all you have already said. Everything.
Yeah.
Okay. So this is the chart which says that this type of diet should be given to the patient.
The fall prevention
Exercise,
is something
we have
we have
already
not discussed.
enumerated all the.
So
that
fall
is
prevention,
Yeah,
fall
that
prevention we have not discussed. So that is also a very important aspect. And patients should also be encouraged to do balancing exercises.
Yes, that is important because sometimes
and to wear good footwear while exercising
and also her vision is losing, so she has to.
She has to do that.
And all those things she has to take care of. Okay. So anyway, this is all we have come. Now, calcium supplements, I think everybody knows, so I'll just quickly show this. So anybody wants to speak on this? Calcium supplement and vitamin D, we all know about this.
I will say here, like the dose, recommended dose is more than 800 milligrams, but not more than 1200 milligrams. We should include dietary and the supplement tablet also, and to limit 500 milligrams of calcium at one time, because there are patients who, if they have to take 2 tablets per day,
Many times
they'll take both
patient
the
comes and
tablets
asks na कि हमको इतना calcium देरी. Yeah. Another thing, patient comes to us and tell कि आप मेरे को इतना calcium दे रहे हैं, मेरे को तो पथरी हो जाएगी, stones हो जाएगी.
So they should know that the dietary calcium will not cause hypercalciuria, number one. Number two, the newer calcium, like the calcium citrate, maleate and all that, they don't cause calciuria so much. And second, patiently also should additionally be well hydrated. So that will itself will also, not lead to renal stones. Same with vitamin D, the optimum, the cholecalciferol is a preferred therapy, and mainly they should be given maintenance, like once in a month during the summer months and twice in a month during the winter. That is also equally important, because there are people who keep on taking weekly vitamin D3 for years together, because once you started. So when we give them therapy, if there is deficiency, we should insist that after 8 weeks of weekly D3, then you should go to maintenance therapy of monthly and or every 15 days.
Yes. So very nicely said. Now, Dr. Archana, you have to say which hormones to prescribe for her and why. Dr. Archana.
Yes, ma'am. Ma'am, actually, postmenopausal osteoporosis being the most common bone disorder and is related to estrogen deficiency. And here she is in early menopause, and she is already having risk factors. Her mother is osteoporotic. Then she has an Oster score of 18, which is moderate risk. She has thyroid
which MHT
disorder.
like this?
So, ma'am, in this
So,
case, because she is 42, I would
we
like to
have
give
already
her
discussed this also.
I would like to give her low dose combined oral contraceptive pills.
Okay.
Which will bring her cycles also, and also give her management for her osteoporosis also. Give a reduced risk for osteoporosis. So this will benefit her by increasing the bone mass also. Sometimes with HRT and COCs, we see the BMD
So you have
sometimes
to
increase also.
individualize the patient.
Ma'am, because she is 42 years old, till she reaches her menopausal age, we would like to prefer to give COCs, and after that we switch over to the MHTs.
Okay. Any difference of opinion from anybody in this patient, 42-year-old? No. Okay.
Pratibha, can I add something?
Yes, madam. Yes.
Dr. Shobha Gudi here. Can I add? See, in women requiring contraception,
Hello. Yes,
can you hear me?
Yes,
Yeah.
ma'am.
Yes,
Yes,
ma'am,
ma'am.
we
You are
can.
audible.
Yeah. So there is a risk of pregnancy for 1 year after the final menstrual period,
yeah, that is what she.
right? So if you are stopping the COC, okay. If you are stopping the COC out of concern, no problem. It's patient's choice and your choice, and start MHT. But MHT will not give contraception, so the couple has to be alerted that now, for 1 year still, so they can adopt another method. Or if there is because whenever we prescribe COC, it is always according to the MEC criteria. You have to use the MEC criteria. The reason may be anything why you are prescribing COC. You have to prescribe according to MEC, the criteria. So if she is fitting into category 1 and 2, then you can tell them that for another 1 year it is possible under close surveillance to continue. If you feel, especially if the menopause has happened like 47, 48 years, a little early it has happened, and then always there is a lot of difficulty in
very valid point,
diagnosing
madam.
menopause. No, diagnosing menopause when a woman is on COC is also difficult. It's not easy.
Yes.
Yeah.
Yeah.
Okay. So these are the issues. Yeah.
And we have to stop COCs first for 4 weeks, and then we have to go for an FSH.
If you want.
Menopause.
Now, Dr. Archana, you are there
Yes,
now?
ma'am.
Hello.
Yes, she's there, ma'am.
Yes,
She's
ma'am.
there.
So now either hormonal treatment is superior or no treatment. Now what do you say?
Ma'am, definitely hormonal treatment is superior
Now,
than no treatment.
in this case, we have already said that we are
But
giving
the
hormones.
only thing is we have to rule
Why?
out the
Only
risk
for
factors.
what you are. And so this is the data which says, and this is MHT started less than 10 years post-menopause in 60 years of age, reduces the risk of all-cause mortality and CHT as compared with placebo or no treatment. And so finally, the individualizing the MHT is the key recommendation for our guidelines. We have already discussed everything for all things. Now, for Archana, Dr. Archana, again, this is for you. What are the options, other options available apart from HRT? We have already talked about HRT. Then what are the other options available for this patient? Dr. Archana? Archana, she's there. Or anybody can take. So these are like raloxifene, bisphosphonate, then desamamab, then teriparatide and calcium and vitamin.
Ma'am, Reshmi can
Archana,
take it.
Yeah, I'll take. Okay, so like we've discussed till now, HRT is available, which decreases the risk of fragility fracture while taking HRT, and the benefit is maintained during treatment but decreases once the treatment stops. It is basically reversible. And like we know, HRT is recommended only up to 60 years of age and or up to 10 years of menopause, not beyond that. And
what about if the patient has continued, I mean, she's taking HRT and she's very much
so if the patient is
comfortable
continuing
and she doesn't want to stop after 60 years.
If she is continuing HRT, she is comfortable, there are no contraindications, and she's more than 10 years menopause or she's more than 60 years of age, then with adequate counseling, she may be allowed to continue with HRT, but the counseling has to be done and there has to be stringent follow-up also to to find out whether she's developing any other complications. Or we can change, like instead of hormonal, she can be shifted to some other form, like we can shift her to tibolone probably. So tibolone has very good effect on the bone mineral densitometry for prevention of osteoporosis, and it is comparatively safer also. So because all forms of HRT will protect the bone. Or we can, if she's high cardiovascular risk, we can shift her to transdermal also, though less effective for BMD, but still effective. Then there are other agents available that like raloxifene, but like it will increase the hot flushes. Otherwise, it's safe. Then bisphosphonates is something which can be given to women beyond 60 years of age and beyond 10 years of menopause. Like even you can give bisphosphonates up to 70, 80 years of age, and it is very safe. The only thing, the GI side effects are bad, so they have to be counseled for the same. The oral bisphosphonates for that, and AVN, and also for on long term bisphosphonates, AVN is a known avascular necrosis of the TM joint is a very common complication.
Drug-free period can be given.
Yeah, so that drug-free holiday has to be given to them. So any form of HRT with adequate precautions and with proper counseling, and also stressing on proper follow-up. The patient should not be lost to follow-up. They should be counseled for the same, and it should be I document everything, so it should be documented also. They can be given for a long time. So denosumab, they are injectables. Teriparatide is also available. They're injectables, but expensive, but still available. Now for bisphosphonates, even we can give zoledronic acid, injectable zoledronic acid once a year also has very good response. It improves a BMD and very good response with osteoporosis. And not to forget the calcium and a dear old vitamin D3.
Yeah. Thank you, Dr. Reshmi. Now, Dr. For Priya, this is 60-year-old woman with osteoporosis and has concomitant hot flushes now. So what HRT you are going to give? We say that estrogen is very good for osteoporosis. So what about for this patient? Are you going to give?
Madam, in this case, I would not like to give her MHT because if she's already on MHT, then you can continue it for some time. But otherwise,
No, she was not on any drugs. Suddenly.
No, so she will need bisphosphonates or other thing, and we know that the
Why
window
you
of
should not be giving MHT?
We've already discussed that when it is within 10 years of this and above 60, we are more scared of the other possible, comorbidities and all which may be there. And I would try to maybe give her the alternate, means besides the bisphosphonates for the osteoporosis, try and give her the alternative therapies for your vasomotor symptoms because she also has hot flashes. And oral, I mean systemic MHT, I would like to avoid. And if it is not relieved with the alternative therapy, then maybe we can consider transdermal, but not the oral systemic.
So that is mainly because of this timing hypothesis, which I think everybody knows. I don't need to tell this again because time is short now. So now, next question is for Dr. Reshmi Banerjee. 51-year-old lady, Gravida 3, para 2 abortion 1, have severe flushes, night sweats and insomnia, and she had her last menses 24 months back. She has her BMI 27 and her elder sister died of DVT in a postpartum period. And she has come to know from Google and is extremely apprehensive to take any harm. Now, what are you going to relieve her anxiety, counseling?
Yeah, so here she has severe vasomotor symptoms. She is definitely menopausal more than 2 years after the final period, and she is obese also. So here for her, according to and her sister died of DVT in the postpartum period. So according to guidelines, the Asians are overall at a lower risk for DVT, but since her sister had in the postpartum period, she may not be so much at risk. Number one. Number two, transdermal estrogen therapy is better choice, is a good choice of estrogen replacement therapy for her.
Yeah, so transdermal MHT is the better choice for this patient.
Is a better choice for her.
So this is what now. This is again, what are the indications for the use of transdermal route for estrogen as a first-line therapy?
Yeah, so like we said, all the people who have contraindications to oral therapy, they are the indications for transdermal. So one is personal choice, migraine, diabetes, controlled hypertension, gallbladder, hyperlipidemia, that is hyper-TG, or the Indian form of this thing, dyslipidemia, obesity, smoking, and previous history of ET.
So high risk, avoid MHT, definitely is caution with MHT, and low risk acceptable for. Now,
so there was a question, name of transdermal. So you have available in the form of Istrabet gel and Lenzetto spray. So they are newer ones which are available.
That can be used. Does combined MHT only treats vasomotor symptoms? whether it is a myth or it is a reality.
No, like it does not only treat vasomotor symptom, it also has protective effect on the bone and cardiovascular system.
Okay.
And also, of course, a mood, a psychological mood, and I mean all other symptoms.
Mood
So it is not
swings,
only
everything, you know,
VMS.
and fracture prevention.
Yeah.
Yes. Okay. Now this is for Dr. Madhumita, a 56-year-old menopausal for last 7 years, present with
Recurrent urinary infection she's presented. Yes. She also has some urinary incontinence.
On
Yes.
further questioning, she reveals that sex is pain and that she feels burning and soreness at vagina with sex. So she has been avoiding it. On examination, vaginal wall is very dry and atrophic. And in fact, I mean, PV examination smear is also very difficult to take. So what are you going to, what is she suffering from and how are you going to manage this patient?
I mean, this is a typical case of genitourinary
Ma'am, time is up.
menopause.
Yes, okay, just one.
So this is a typical case of genitourinary syndrome of menopause, and these patients actually they benefit and they show significant improvement with vaginal estrogen preparations. So they respond very well, and as such, vaginal estrogens they are even now she's 57, but even after even when taken for prolonged number of years, even after 60 years, usually these vaginal preparations they don't increase the blood level of estrogen much. So they are considered to be very much safe. So there are various preparations like estrogen cream, gel, and we have also vaginal rings. So these preparations can definitely be used.
Okay. So these are the creams and gels and even sprays are available that can be used. Now, does you
And
need
along with this, pelvic
endometrial
floor exercises are also advised, ma'am.
What?
Ma'am, pelvic floor exercises along with the vaginal estrogen. We
Hello?
advise
Yeah.
pelvic floor exercises
Now what?
also.
Yes.
So does she need routine endometrial surveillance? As such, the guidelines don't say that we have to routinely screen the endometrium. But then suppose in case any spotting, any unexpected bleeding or anything, she has to report back. So that is one important
What about
we have
the
to
role of,
educate her.
yeah.
Yes.
And what about the role of vaginal estrogen in breast and endometrial cancer survivals?
Safe.
So
Safe,
in,
yeah.
yeah, so in these patients, suppose in case,
Yeah.
suppose in case they
One
completed
line, it is safe. It can be given.
Yes.
Okay.
Yes, ma'am. If it's considered that they're cured of the cancer, then they can definitely be given.
Yeah. Now 50. This is for Dr. Priya. Priya.
I think
55-year-old
Pratibha, yeah,
Peronia.
I think we will wind up and give the post test because I think that will be important.
People are leaving now, so
Okay.
Yeah.
you can take some take-home messages, ma'am, Pratibha ma'am, if you want. And then
Yeah.
we
Yeah,
Give
so
us the
can
slide on.
all our panelists can give one liner.
Yeah, because I think Pratibha, you did a very good panel discussion. It has come out very well, actually.
Thank you, madam.
Yeah,
I
yeah.
just wanted
So
to
I
ask
think
this question last actually. One
वो तो
question.
हमेशा ऐसे ही लगता है और पूछे.
No.
Okay, there
I
is.
think we have one-liners, as Pratibha ma'am said from
Yeah,
everybody.
concluding comments. Concluding comments. Thank you.
Don't miss the window of opportunity.
Yeah.
Perfect.
Don't shy away from MHD.
What is that? Labial fusion.
Labial fusion.
Fusion.
And what about the treatment for this?
You can give
Either
local
surgical
estrogen
separation and
or
local
surgical.
topical estrogen.
Topical
Yeah, topical
estrogen creams.
estrogen or surgical separation. Yes.
Okay. So thank you so much. And now I will request all our panelists to give one liner, one concluding remark. Dr. Reshmi Banerjee, we'll start from you.
I said don't shy away from HRT both for doctors and patients. We are also, I mean, I face it every time I start MHT, my physician friend stops it. So we need to educate them.
So that is Dr. Archana Singh.
I said, ma'am, don't miss the window of opportunity.
She was the first one to comment, actually, right?
Okay, I did not hear. Dr. Priya?
Lifestyle modification is absolutely essential. You need to start it much before you actually reach menopause. So lifestyle, I think exercise, good diet, everything is important.
And that should be started early. Not
Yeah,
at
much earlier. You don't miss the bus. Yeah.
Yeah, miss the bus. Madhumita, Dr. Madhumita.
Yes, ma'am. So most of the time, most of the symptoms that menopausal women face, it's attributed to the normal period of normal things that they. It is just like a lack of sleep or whatever they go through, and all these genitourinary symptoms is attributed to the normal symptoms of menopause. So always, like sometimes, so the patients don't exactly open up when they come to us. Like they just consider, okay, it's normal. I'm getting old, so that is why it is like that. So we have to sometimes probe, ask them, are you facing this? So because they just attribute it to the normal menopausal changes and then they don't come out, they suffer in silence and they don't open up. So I think definitely that thing has to be looked into.
Shobha Goody, madam, last concluding remark. She's gone.
Hello, hello.
Yes, ma'am. Yes,
Yeah,
ma'am.
I think it was an excellent panel, and I really appreciate all the panelists. Everybody has prepared, and of course, some of them are quite senior in IMS, like Reshmi is our colleague, and she has done so much work for her committee. So it came out very well, and
Thank you.
a lot of good messages. I think concluding remarks about MHD. I think we must take feedback from the audience. How did they
Audience.
learn?
Yes.
Ah.
Yeah.
So I
So
think we
only,
have spoken.
yeah, one thing I would,
Any two audience can be allowed to unmute and give feedback after the
madam,
post test.
we'll
After
proceed to
the
the
post
post
test.
after the post
Post
test.
test pehle. Yeah, pehle
We
post
are
test.
already
Yes.
exceeding time. Only one thing
Yeah.
I would like to say, what inspiration I have drawn from all the
Archana Dwivedi,
panelists.
you want to say something?
Yeah,
Last.
that is what I'm saying. It's a concluding thing. I'm thankful to all the panelists and obviously Pratibha ma'am at the last moment I roped her in, and you have done so much justice to the point. If I have to make a
Very
concluding
good.
remark,
Very good.
looking into Shobha madam, you and all my worthy panelists over here, the me time, keeping yourself pampered and in a good shape is one thing you should always follow. So I'm loving that everything about everybody out here. So thank you for giving us time. Yes, Pratima, you're saying something? So thank you for taking out time
Thank
and
you.
doing
Thank you.
such thorough. So I think we'll hand over to the host now to start the post test because people are anxiously waiting about for that.
Thank you. Thank you, Archana. Thank you, everybody, for giving me this opportunity. Thank you, all my panelists. Thank you.
Thank you, ma'am.
So till she's sharing the screen, I'd like to also thank especially Pratibha ma'am, Archana, Madhumita, Prerna, and Priya who have been with us all these 3 days. And I know taking out time from busy schedule and conducting the program along with us so well. Thank you so much, four of you.
Thank you so much, ma'am. Thank you so much for the opportunity, ma'am. Thank you.
Thank you.
So Nilima, can we have the post test, please? And we'll keep ourselves mute for 10 minutes till the people are attempting. The link will be shared in the chat box. Yeah, so we start now. So I think everybody has completed and submitted, and I'm very thankful to everyone because lovely feedbacks on the chat box. I think that's a great encouragement to the team and will motivate us to go further. So, Archana, would you like to read out the answers before we open
Yeah,
the house?
Priya will read out the questions and I will read out the answers.
Okay, just read the answers. Don't need to read everything. Okay.
Yeah.
Okay.
So Nilima, can you share it again for the benefit of Priya and Archana, please?
Okay. Question 1. Which mind-body therapy is recommended by North American Menopause Society for alleviating VMS in menopausal women?
The answer is cognitive behavioral therapy. A.
Question 2. Which non-hormonal drug is approved by FDA for the treatment of menopause-associated VMS?
Answer is C. Paroxetine salt.
NAMS recommended following drugs for VMS except?
Answer is C. Clonidine.
Fezolinetant is which category drug which is used now for VMS in menopause?
That is NK3 receptor antagonist. Answer D.
The following are direct indications for transdermal estrogen except?
Answer C. Diabetes mellitus.
Regarding long-term maintenance therapy for vaginal estrogen for urogenital symptoms?
D. Twice a month for the months 2 years.
Which level of defect results in vault prolapse?
Answer level 1.
How can one prevent vault prolapse during hysterectomy?
Answer 2. By incorporating uterosacral ligament, pubocervical and rectovaginal fascia in the vault.
Advantages of laparoscopic pectopexy?
All the above.
All are indications of MHT except one.
D. CBD.
Best progestogens for MHT are all except one.
C. Medroxyprogesterone acetate.
Regarding psychological issues in women relating to menopause as feelings of loss of femininity.
True. True.
Regarding psychiatric symptoms of menopause as more women present more with psychiatric illness like depression and anxiety as opposed to psychological disturbances such as loss of confidence and low self-esteem.
False.
Regarding treatment with HRT for psychiatric disturbances such as insomnia in menopausal and postmenopausal women may respond to estrogen.
True.
What is the dose of tibolone?
2.5 milligram per day.
Tibolone is suited for women with
dense breast.
Which statement is true?
Tibolone may decrease body fat.
Which hormone or hormones do alpha and beta isomers of tibolone bind to?
A. Estrogen.
Tibolone can improve mood and sexuality due to which component?
C. Androgen.
Regarding depressive symptoms in women, an increase in psychiatric morbidity in women aged around 45 to 50.
A. True.
That's the last, I guess.
Yeah, that's the last. Thank you, Archana and Priya, for hosting the session so nicely. And I would like Nilima to unmute Dr. Madhuri Joshi and Dr. Aditi Rathore for their audience opinion. And then we can have a concluding remark. Sarita ma'am is busy with something, so she won't be able to join. So, Madhuri ma'am and Aditi, just share your opinion. Please unmute these two.
Yeah. Good to see you now physically also, Dr.
Yeah.
Archana and Dr. Goody, madam. Okay, so I always feel that if we give menopausal care like antenatal care in a formatted way, so if our females are coming regularly like antenatal care, and we have to really reiterate that we have something for them to give in a formatted way, and which is really beautifully available in our website, good practice guidelines and everything. We are really going to help our females in many ways. So I always say that and follow that formatted care like antenatal care. Menopause is also a dream which will come true if we really attend such meetings. And thank you ICOG for making such great program. Thank you very much.
Thank you, Madhuri ma'am. I know you're doing good work. You have also designed the app, and we'll be keeping it in mind when we start working next year. So thank you for the feedback, ma'am. And Aditi, some words from you would be encouraging.
Thank you, ma'am, for allowing me to express myself. Excellent organization by you people, first and foremost. And most of the time in my OPDs, I find women perimenopausal and postmenopausal who are at a loss to what they are suffering from, and they cannot understand their symptoms. And we as clinicians are also at a loss to how to counsel them and help them out. So this series has been a lot of help, so that it will guide us to have a dedicated menopausal clinic. So it will help all the people who have attended the classes, will go through the recordings, because it is a one stop center as such for everything, right from it has covered every aspect of menopause so beautifully, and it was the need of the hour. So well done, and thank you so much.
Thank you, dear Aditi, and thank you, Madhuri ji, for your feedback. And there are many feedbacks which are in the chat box, keeping us encouraged. So finally, I would like to deliver the vote of thanks. So Shobha madam, would you like to do the honors? Okay. So
Hello.
Yes, ma'am. You're audible. Would you like to give the vote of thanks for?
No, you give the vote of thanks. I will just say a few words. I mainly wanted to thank the ICOG office bearers, because many complimentary messages are coming, and it is all because of the vision of Dr. Parul Kotrawala and Dr. Sarita, Dr. Parag, and also Dr. Sheila Mani, that this course has been conducted. And it is amazing the way the conveners, the coordinators for the 3 days have conducted, Archana. I'm so very delighted and thankful to all these girls, Priya and Archana and Madhumita. Yeah, all of them. Wonderful work by them. And I think the speakers have done very excellently. The final vote of thanks belongs to you. I just wanted to thank the two viewers also, the two audience who gave their inputs also. And I agree with them that focused menopausal care and dedicated menopause clinic is the need of the hour. And let us all, work towards that. Archana, please. Thank you very much.
Thank you, Shobha ma'am. Actually, during the WWW conference, myself and Geeta ma'am were discussing that we need to do a ICOG menopause certificate course. And I'm thankful to Dr. Parul Kotrawala sir, Parag Bindiwala sir, and Sarita madam to take it to a next level. In fact, there was a learning experience for me, my colleagues, everybody in the house right now. So without delegates and without the worthy speakers, it was not able to be a successful program. So I thank everybody, my master coordinators also, and Team ICOG. Nilima, thank you for this beautiful academic platform and being in touch at a very prompt app
We
level.
must thank Nilima.
Yeah,
Nilima needs to be thanked, really.
So literally, actually, she never lost contact, whatever you say.
Yes.
So that is what is the academic platform success is all about. Sarita ma'am wanted to join because of some commitment. She's not here. So I'm thankful to everybody out here, all the speakers in last 3 days. And those who have given pre-test and post-test, there's a question when you'll get the certificate, you'll get it in your mail ID. So just wait for the time and keep learning. This is a learning process, and I hope everybody was benefited. And I request Team ICOG to conduct such certificate programs because they are really essentially very helpful in our private and practical practice points. Thank you so much, everybody.
Yeah.
Good night. And
thank you. Thank you.
Yeah, have a happy
Bye.
Diwali and a happy New Year as a Gujarati here. So I
Thanks,
wish to
everyone.
see smiles on everybody's face for the rest of the year and the coming year as well. Bye bye. Signing off. Nilima,
Bye.
you can
Bye.
take leave now. Thank you. Thank you so much, ma'am.